Sir Dr. Madhu Dixit Devkota. Introducing Dr. Mahesh Kumar Maske, he is the Executive Chief at Nepal Public Health Foundation. He has done his Doctor of Science in Epidemiology from Boston University, USA. Regarding his work experience, Dr. Maske has served as a Chief Advisor to the Honorable Deputy Prime Minister and Minister for Health and Population in Nepal in 2006 to 2007, and also was the chair to the South Asian Forum for Health Research. He was also the executive chair at Nepal Health Research Council since 2006 to 2009. He was also a member of Advisory Committee for Health Research WHO SHERO from 2007 to 2009. He was also an executive vice chair, New Health Policy Drafting Committee, Ministry of Health and Population, Nepal in 2017. He has received distinguished alumni award from Boston University and has done 4 PhD supervision and has been principal investigators and co-investigators in different research papers. He is also the lead of Nepal Center of the Global Health Network, Oxford. Likewise, introducing Professor Dr. Devkota, she is a public health expert, researcher, and academician in Nepal. She serves as an Associate Dean in the Department of Community Medicine and Public Health. Currently, she is the Executive Chairperson of Upendra Devkota Memorial National Institute of Neurological and Allied Sciences. Through her academic leadership, she has contributed over 10 health policies in the country. Once again, I would like to warmly welcome both of our chairs and kindly request them to take this session. Over to you, sir. Sir and ma'am, thank you.
Thank you very much for your kind introduction. And we'll start this session, which is very comprehensive. As you know, this is about mental health and well-being, one, primary health care and universal health coverage, and also financial issues. So what I want to say is that the mental health challenges has been a big issue, not only in Nepal, but all over the world. And very recently, Nepal's Supreme Court has ordered the government, and I think the credit goes to an organization called COSHIS, who launched, take this forward to the Supreme Court. And so that's enough telling, how much important is that the Supreme Court is ordered. And what is interesting is that India immediately followed that. So it was in April in Nepal, and I think it was in May, June in India, also Supreme Court followed with that one. And one thing we have to be a little bit probably careful with the global trend is that now we're bringing both mental health and neurological problem together because they overlap. There has been too much of segregation. So now the current trend is mind-brain health, okay? So this is something in the spirit of that we'd be discussing about, because mental health cannot be, separated from brain health, okay? So that is one thing I wanted to say. And another is the universal health coverage, which goes very strongly with MHCAP and the mental health care that Nepal government is trying to do. And so if you remember our constitution, the clause 35, it says very strongly about what is the Nepali people's right for healthcare, okay? So having that perspective, let's begin our deliberations and discussions about mental health program and universal health coverage, and also financial issues related to it. So I want to invite Dr. Binita Dungel, who would be talking about National Mental Health Program, achievement, challenges, and the way forward. And she is a very well-known psychiatrist and researcher. For her clinical psychiatry, she has contributed lots. She works in Patan Academy of Health Sciences and has collaborated extensively in national level mental health researches. So, Dr. Binita Dungel, are you okay? Good. The floor is yours, ma'am.
Thank you, sir. I'd like to correct that. I was working in mental hospital. Sorry for that. So, okay, respected chair, and distinguished guests, and my dear colleagues. On behalf of Epidemiology and Disease Control Section and City and Mental Health Section, I am presenting on behalf of them National Mental Health Program, Achievement, Challenges, and Way Forward. So, we all know that mental health disorder contribute a major part in the global burden of disease, especially disability. So, and in the context of Nepal, it has a dual challenges. On one hand, the prevalence of mental health is increasing day by day, and on other hand, the unmet needs from the beginning are high. So, in this context, Nepal has there's a increase in burden on health, overall economy of the health, national economic system, and this makes the mental health as a public health priority. So going to globally, we can see 1 in every 8 people has mental health disorder. That is about 1 billion people are living with the mental health disorder at this time. And about them, 82% of live in low and middle income countries like Nepal. So according to Global Burden of Disease Report 2023, which is published in October 2025, we can see the mental disorder, substance use disorder accounts similar share across all 3 regions, globally, Nepal and Southeast Asian region. And in terms of years lived disability is also mental disorder burden in Nepal is aligned with the global trend. So this caused the urgent action to prioritize mental health in the national health system. So we have National Mental Health Survey for Nepal data, which shows that 10% of adults and around 5% of adolescents and children has mental disorder, and major depressive disorder most commonly identified, and also suicide, which the situation of which is very critical. So suicide is one of the preventable cause of death, and we have like 6.58% adult and around 4% of adolescents and children have current suicidal thought at this moment. So addressing this challenge is a very difficult. So this also reflects that mental disorder is very common and it can affect people across all ages. Now we see the burden. Burden is high. Despite this, mental health service coverage is very limited. Only 8 out of 10 people, 8 out of 10 do not receive any treatment. And now shifting to another part, then what is the basis of the program that we run? Nepal had made progress in making legal and policy framework, such as Constitution Nepal 2015 has included health as a fundamental right of every citizen. Similarly, public health service includes the mental health in the list of basic health service, and there's also legal provision to promote the respect and dignity of people with a mental health disorder. Therefore, we have documents, but implementation is still a challenge. And we have also successfully developed national mental strategy and action plan in 2020 to 25 with key objectives of ensuring universal access of mental health service, strengthening the resources, promoting the mental health awareness, protecting the fundamental human rights, and promoting the health system, research, and studies. So this is the roadmap for the mental health development in the nation. So far, we talked about burden. Then, despite all we have achieved, what we have achieved in the last recent years, our achievements are like. So I just described Nepal. We developed the National Mental Strategy and Action Plan, launching of Suicidal Prevention Action National Plan 1166 in 2021, National Mental Health Program 2022, and in upcoming days we have initiatives such as Telemental Health, Kulaman, which is a district mental health strengthening program, and school mental health framework establishment. These are on the way. So this reflects a positive progress, but this requires a continued effort. On the part of another achievement, we have service availability. Now, we have at least one psychosocial counselor at each municipal level of all 77 districts. But this is limited number of specific service, but it is better than the before. So we have 20 districts out of 77 where outpatient and inpatient psychiatric services are available, whereas only 16 have outpatient service available. So more to go. So this is about the mental health cases that is recorded in HMS. If we see this graph, we can see the data are increasing every year. So mental health case body is increasing, I agree. But if you see from the other part, we can see that data resource has been strengthened. More mental health cases has been identified, recorded, and reported. So, and also stigma for care-seeking behavior is going down in. So we take this as a part of achievement. So in mental health condition, in last 3 years data also, anxiety and depression are the most commonly identified condition. Now, we know about Sustainable Development Goal. There are 17 goals. Nepal joined it in 2016 during first year of 14th third 3-year plan, and now it is extended in 16 developmental plan period. So in this time frame, Nepal has made strong progress in economic strengthening, poverty reduction, which is coded by green, and moderate progress in other areas, whereas in employment area it's lagging still. But I will say the 3 is at least moderate progress. I have coded its rate. Why I coded rate is, I coded rate because of this indicator, suicide mortality rate, which is one of the indicator in Sustainable Development Goal 3.4. This shows that we have to, our target is 4.7 by 2030, and we are at 24 per lakh population, which is very tedious task. I will not say impossible, it's very difficult. We need strong, coordinated, multi-sectorial prevention effort. And for this, we are now in a final phase of endorsement of suicide risk assessment guideline, and we have also successfully developed suicide registry at Lam district and Baglung district in digital version, and it's a pilot project. So with this, I will say for mental health is embedded within the sustainable development goals. So there is for development of sustainable mental health is very important. So it is not only the mental health. So it is mental health is determined by the social, economic, and other determinant. So we need at this time our approach should be evidence informed resource governance. So despite all this achievement, everything, we implementation, legal guidelines, and so many progress, we have challenges. So what are the challenges? One is low funding, that limits scaling of the service. Another is less number of workforce, that limits the service delivery, and persistent stigma, which affects our care-seeking behavior. And most important is the less integration of mental health into general system that makes the service inefficient. So what are the plans that we can do? Despite this, we need to address this. So our focus would be on these priority areas. One is expanding workforce, increasing investment in health, mental health, strengthening community mental health service, and the most important is promoting data and research. So there are many areas still mental health need research, like epidemiology. Even we can see the National Mental Health Survey is of 2020, from which we were providing the data, so it's needed at this moment. And another is, I will say about child mental health, addiction, geriatric. There are many areas of research still needed. With this, I conclude my presentation. Thank you so much for your attention.
About 2 minutes left, maybe. What is that? No, you just maybe you can have some time for the questions or queries for her, because.
10-minute presentation, I lost.
If you have, okay. If you don't have, I will ask. Okay. I just told you about the Supreme Court order, no? And it says exactly these two things that you have mentioned. One is the human resources deficiency, so how it instructs the government, to increase the number of people, qualified professionals for that, and increase the budget. And
yes.
You have mentioned both. Yes. So what the government is doing now for that, and we know that in interim period, Dr. Sudha Sharma, who's the minister, also talked about this. So have they done anything about that? Do you know about that?
To my knowledge, मेरो knowledge mental health को अहिले यसपालि त budget घटेरै आएको छ overall health sector मै. We all know that less than 1% of that budget is invested in mental health. So यसपालि पनि सिलिङ कम नै छ, तर हामीसँग साझा संस्था पार्टनरहरूको सहयोगमा कार्यक्रम त हुँदै आएको छ, उहाँहरू बिना त भएको छैन. त्यसैले यो मञ्चबाट उहाँहरूलाई थ्याङ्क यू भन्न चाहन्छु. र अर्को कुरा मेन्टल हेल्थको वर्कफोर्स चाहिँ हामी मेमेन्स केयरको ट्रेनिङ हजुरलाई थाहा नै छ होला, टास्क सिफ्टिङको बेसमा काम गरिरहेको छ. एटलिस्ट मेन्टल हेल्थ प्रोफेसनलहरू लिमिटेड हुनुहुन्छ, हरेक ठाउँमा पुग्न नसके पनि हामीले एमएस ग्याप गरेर प्यारामेडिक्स नर्सिङहरूलाई एटलिस्ट मेन्टल हेल्थ केस नछुटोस्, एटलिस्ट स्क्रिनिङ गरोस्, इभन ग्रासरुट लेभलको फिमेल चाइल्ड हेल्थ भोलिन्टियरलाई पनि ग्याप दिएको छौँ ताकि मानिसहरूले चाहिँ नछुटोस् उनीहरू हाम्रोमा आइपुगोस् भनेर, ताकि एटलिस्ट मेन्टल हेल्थ केस स्क्रिनिङ र रिफरल भइदियो भने त कम हुन्छ नि। र सुसाइड भनेको त हामीलाई इम्पल्सिभ हो नि थाहा छ नि त, यदि कोही मान्छेलाई नेगेटिभ थट आइरहेछ भने उसले एउटा साइकोसोसियल काउन्सिलर जुन आई सो यु इन द पिक्चर 77 डिस्ट्रिक्टमै छ, त्यहाँ गएर भन्यो भने एटलिस्ट उसलाई टाइम बाइङको टाइम त भयो नि, उसलाई त्यो टाइममा हामीले वी क्यान सेन्ड देम टु द नियरेस्ट। यसरी हामी काम गरिरहेको छौँ। र यस अफकोर्स मेन्टल हेल्थ प्रोफेसन एकदम लिमिटेड छ, जति हुनुहुन्छ मोर अर्बन एरियाजमा हुनुहुन्छ, इभन माइसेल्फ आइ एम वर्किङ इन द सिटी एरियाज होइन। त्यसको लागि चाहिँ अब सरकारले ओएनएम सर्वे गर्दै हुनुहुन्छ, जहाँ जहाँ ल्याक छ त्यहाँ प्रोभाइड गर्ने।
Thank you. Maybe I'll go to the next. I do have some thoughts on mental health issues. I will hold it for now, and I'll maybe towards the end. I would like to summarize the points that you've raised. Okay. Am I audible? Okay. Thank you, Dr. Julia. May I now request the second speaker, Dr. Sachin Ghimire. The topic of his presentation is Social Suffering in Russia and Ukraine, a tussle, a necropolitan analysis of Nepali citizens exposed to sordid trafficking. Very interesting topic. Let me introduce our speaker. Dr. Ghimire is currently an assistant professor in the Department of Public Health, Manmohan Memorial Institute of Health Sciences in Kathmandu. He's a medical anthropologist and a filmmaker. He's also a winner of National Youth Talent Award for 2025. What a lovely introduction. How different from what we
15,
usually
15. It's not, ma'am, it's not 25, it's 15.
2015.
Yes, ma'am.
Yes. My apologies. So the floor is yours.
Thank you,
Dr. Ghimire.
Thank you, ma'am. यस सभामा उपस्थित सम्पूर्ण आदरणीय महानुभावहरू र रेस्पेक्टेड चेयरहरूलाई म साधारण नमन भन्न चाहे। मेरो आज प्रेजेन्टेसन बेसिकली लास्ट टाइम इन युनाइटेड स्टेट आई हेड प्रेजेन्टेड इन इङ्ग्लिस एन्ड फर्स्ट टाइम इन दिस कन्ट्री आई वुड लाइक टु टेक लिबर्टी अफ प्रेजेन्टिङ इन नेपाली, द्याट्स वाइ प्लिज बेयर मी। ओके, सोसल सफरिङ इन रसिया एन्ड युक्रेन वारफेयरको कुरा गर्दाखेरि हामीले यो खोइ सरी कसरी हो त कसरी हामीले हाम्रो कन्टेक्स्टको बारेमा नेपाली अडियन्सहरूलाई नै धेरै बताइरहनु पर्दैन। हामी यो बेसिकली डिसेम्बर 23 पछि केही रसियन आर्मीमा गएका केही नेपालीहरूको मृत्यु भयो भनेपछि नेपालमा 81 चाहिँ यो इस्यु ट्रिगर भएर आउँछ र त्यो बेलामा गभर्मेन्टको एटेन्सनमा आउँछ कि 150 देखि 200 जनासम्म मान्छेहरू चाहिँ नि त्यहाँ चाहिँ छन् भन्ने मात्रै सुरुमा थाहा हुन्छ, तर त्यो अथेन्टिक इन्फर्मेसन थाहा हुँदैन। र त्यो बेलामा अब हामीलाई थाहा छ हाम्रो नेपालको कन्डिसन अनुसार अब युथ बल्स छ, डेमोग्राफिक डिभिडेन्ड हाइट छ, त्यसले गर्दा नेपालभित्र पनि जब खोज्ने बाहिर पनि खोज्ने क्रममा अब अफकोर्स अब चाहिँ जब क्रेमलिन्स अब इन्टरनेसनल मिडियाले त क्रेमलिन्स स्क्याम भनेको छ, जब आकर्षक जब र त्यहाँको सिटिजनसिप दिने भनेर रसियाले अफर गरिसकेपछि नेपाल लगायत धेरै देशहरूबाट, साउथ एसियन अरू देशहरूबाट, अफ्रिकन देशहरूबाट, ल्याटिन अमेरिकन देशहरूबाट, त्यहाँ चाहिँ विभिन्न देशहरूबाट मान्छेहरू पुग्छन्। अब यो चाहिँ एउटा अचम्मको कुरा चाहिँ के त भन्दाखेरि जब भएका नि पुग्छन्, जब नभएका नि पुग्छन्, विभिन्न किसिमका मान्छे त्यो हाम्रो नेपाली सिटिजनहरू पनि त्यहाँ पुग्छन्। त्यसले गर्दाखेरि अब यो फर्मल एक किसिमको रिक्रुटमेन्ट प्रोसेस जब सुरु हुन्छ त्यसपछि एउटा छुट्टै किसिमको सोसल रियालिटी नेपालमा सुरु हुन्छ। अब यसमा यो कन्टेक्स्ट त मैले एकदम छोटोमा मात्रै बताएँ। यसमा एउटा मैले कन्सेप्चुअली क्रिटिकल पोलिसी डिस्कोर्स एनालाइसिस भनेको छु। यसमा चाहिँ कुनै पनि डिस्कोर्स, कुनै पनि न्युज, कुनै पनि ओपिनियन, कुनै पनि इस्यु सोसाइटीमा सर्फेसिङ भइरहेछ, फ्लो भइरहेछ भने त्यो एकदम इनोसेन्ट हुँदैन, त्यो चाहिँ नि न्युट्रल हुँदैन, त्यो कतै न कतै पोलिटिकल्ली म्यानिपुलेटेड हुन्छ र पावर रिलेसनहरूले त्यो डिस्कोर्सलाई, त्यस्तो किसिमको न्युजहरूलाई, त्यस्तो किसिमको ओपिनियनहरूलाई म्यानिपुलेट गरेको हुन्छ भन्ने विश्वास क्रिटिकल पोलिसी डिस्कोर्स एनालाइसिस गर्दा हामी गर्छौँ भने नेक्रो पोलिटिकल एनालाइसिसमा चाहिँ नि एउटा साउथ अफ्रिकन स्कोलर एक्चुअली एमएमबे भन्ने स्कोलरले के भन्नुहुन्छ भने यो समाजमा को बाँच्ने र को मर्ने भन्ने कुरा सोभरेन पावरहरूले डिटरमाइन गर्छ। त्यो भनेको चाहिँ सर्टन पावरको कारणले नै को आरक्षित हुने, को संरक्षित हुने र कसलाई मर्न पर्ने बाध्यता बनाइन्छ भनेपछि इभेन्चुअली पावर स्ट्रक्चरले, स्टेट स्ट्रक्चरले कुरा नबुझिसकेपछि, त्यो इन्क्लुसिभ नभइसकेपछि कयौँ मान्छेहरूलाई मार्न बाध्य बनाउँछ। त्यसले गर्दाखेरि को मर्ने र जिउने भन्ने कुरा यो पावरसँग नजोडिकन हेर्न मिल्दैन। यो इन्डिभिजुअल चोइस मात्र होइन भनेर भन्नुहुन्छ नेक्रो पोलिटिकल, त्यो मैले कन्सेप्ट लिएको छु। त्यसले गर्दाखेरि यो दुईवटा कन्सेप्ट लिएर हाम्रो नेपाली सोल्जरहरू कसरी चाहिँ नि त्यो चाहिँ नि नेपाली सोल्जर भन्नु भने नेपाली सिटिजनहरू कसरी चाहिँ नि एउटा मसिनरी सोल्जर भएर रसियन युक्रेन र रसियाको वारमा इन्भल्भ हुन पुगे भन्ने बारेमा मैले आफ्नो प्रस्तुति दिन लागिरहेको छु। अब मैले यसमा अलिकति नर्मली अटो इथ्नोग्राफी त एन्थ्रोपोलोजीमा, मेडिकल एन्थ्रोपोलोजीमा चलिरहेको टर्म हो। यसमा सेमी अटो इथ्नोग्राफी भनेको कारण चाहिँ म आफै रसिया जाँदाखेरि म 3 चोटिसम्म टाइम नपाएर एम्बेसीमा 3 घन्टासम्म लाइन बस्दा उनीहरूसँग गरेको इन्टरेक्सन, त्यसपछि फर्केर आएर हामी 18 दिनसम्म कीर्ति भण्डारीजीले गर्नुभएको काठमाडौँको अनसनमा मेडिकल वर्कफोर्सलाई मोबिलाइज गर्दा सबै फ्यामिली प्लस रिटर्निङ माइग्रेन्टहरूसँग एक्सपोजर भएको, सबैले गर्दा मैले यसलाई सेमी अटो इथ्नोग्राफिक भनेको छु। र अहिले चाहिँ यो नेटनोग्राफी, अहिले अब क्लासिकल वार जस्तो कहाँ के भइरहेछ थाहा नै नहुने होइन। अहिले युट्युबदेखि धेरै मिडियाहरूमा चाहिँ नि यो वारको चाहिँ न्यारेटिभहरू फ्लो भइरहेको हुनाले मैले नेटनोग्राफी एप्रोच पनि अप्नाउँछु भने मैले वाट्सएपमा कीर्ति भण्डारीसँग डाइरेक्ट कनेक्ट गरेका रसियामा युद्ध लडिरहेका सिपाहीहरूले पठाएको भिडियोहरूदेखि लिएर सबै मैले त्यो हेर्ने मौका पाएको हुनाले त्यसलाई पनि मैले नेटनो इथ्नोग्राफी प्लस सेमी अटो इथ्नोग्राफी भनेको छु। अब यो हामीलाई क्लासिकल पुस फ्याक्टरको बारेमा धेरै सबैलाई थाहा छ। जस्तै अहिले मैले अलिकति नेपालीमा भन्नुपर्दा मलाई इच्छा थिएन आर्मीमा जानको निम्ति, तर पनि नेपालमा चाहिँ कुनै पनि अपर्च्युनिटी नपाएपछि मैले टिकटक भिडियोहरूमा ती भिडियोहरू देखेँ, जसले गर्दाखेरि मलाई त्यहाँ एकदमै जान एकदमै आकर्षित, मलाई भित्री मनदेखि एकदमै मन लाग्यो। र हामी यहाँ पुगिसकेपछि अलिकति हामी चाहिँ बेसिक गन ट्रेनिङहरू मात्रै भयो होइन। त्यसपछि अब हामीलाई युक्रेनको बकमुत भन्ने ठाउँमा पुर्यायो र अब बेसिक गन ट्रेनिङ मात्रै दिएर हामीलाई त्यहाँ पुर्यायो भनेर कसैले जान मन थिएन, गइयो अब केही न केही होला भनेर, तर बेसिक गन ट्रेनिङको पुर्यायो भनेर एउटा विभिन्न किसिमका मध्ये क्लासिकल पुस फ्याक्टर एउटा त्यो मैले त्यो भन्न चाहेँ। अब यो युक्रेनको क्याम्पमा भएकोहरू। अब नेपालको अफिसियली अब पोलिसीमा चाहिँ सुरुमा अब खासै नेपालको चाहिँ अफिसियली पठाउने बायोल्याट्रल ट्रिटी भएको कन्ट्रीहरूभन्दा अन्त चाहिँ सोल्जर पठाउने नेपालको नीति छैन। अब नीति नभइसकेपछि के त अब गभर्मेन्टले पछि चाहिँ अलिकति यो सतहमा न्युजहरू सर्फेसिङ भइसकेपछि गभर्मेन्टले चाहिँ नो अब्जेक्सन लेटर लिएपछि मात्रै जान पायो। नो अब्जेक्सन लेटर छ भने मात्र पाइन्छ, नत्र पाइँदैन भन्ने जस्तो एउटा क्लज त लगायो। तर नेपालबाट मात्र होइन, दिल्लीबाट, युएबाट, संसारको थुप्रै देशबाट गइरहेको ठाउँमा नेपाल गभर्मेन्टले रोक्न सक्ने त्यो सम्भावना पनि थिएन, तर अलिकति देखावटी केही क्लजहरू चाहिँ लगाएको थियो। अब यहाँ अरू त्यस्तै भनेपछि अब जस्तै युट्युबमा कोही युट्युबमा हेरेर गए, कोही चाहिँ नि टिकटकमा हेरेर गए, कोही कता गए। तर यसमा चाहिँ नि जसरी युक्रेनतिरको कुरा भयो त्यो त अब यता मस्कोतिर पनि त्यही छ। मस्कोमा पनि पुर्याइन्छ, त्यसपछि अवान्त गाडी भन्ने ट्रेनिङ सेन्टरमा पुर्याइन्छ, त्यसपछि 5 दिन 10 दिन 15 दिन ट्रेनिङ पछि मात्रै उनीहरूलाई 10 दिन 15 दिनकै ट्रेनिङको इमिडिएटली पोस्टिङ गरिन्छ। अब यसमा किन पोस्टिङ गरिन्छ भन्दाखेरि अलिकति युक्रेन साइडको मिडियाले चाहिँ नि ग्रिन्डर यो चाहिँ नि मिट ग्रिन्डिङ गरेको, अब भनौँ न युक्रेनियन आर्मीहरू कहाँ छ भनेर केही 10-15 जना 20 जना 50 जनाको फोर्स पठाएपछि युक्रेनको आर्मीले हाम्रो नेपाली मसिनरीहरूलाई अट्याक गरी त्यसपछि रसियन फोर्सले कहाँ छन् युक्रेनियन आर्मी भनेर हान्न सजिलो हुन्छ भनेर पठाएको, त्यस्तो चाहिँ नि त्यस्तोको लागि फ्रन्ट लाइनमा पठाएको भन्ने धेरै न्यारेटिभहरू छ होइन। तर नेपाली सोल्जरहरू जो फर्केर आए, जसको युट्युब भिडियो एनालाइसिस गर्दाखेरि पनि लगभग त्यही नै देखिएको छ। अग्रपङ्क्तिमा उ गरेर पठाएको, मर्नैकै लागि पठाएको जस्तो देखिन्छ। अब यहाँ चाहिँ नि अघि नै मैले भनिहालेँ, अब जब क्रेमलिन भनेको चाहिँ नि अब हाम्रो यहाँको सिंहदरबार भने जस्तै रसियाको दरबारलाई, रसियाको स्टेटलाई क्रेमलिन भन्छ। त्यसले गर्दा उनीहरूले जब आकर्षक प्याकेजहरू लिएर आए, त्यसपछि हाम्रो प्राइमरी ल्योरिङ फ्याक्टर चाहिँ पुस फ्याक्टर त ट्रेडिसनल फ्याक्टर छँदै थियो, हाम्रो यहाँको अनइम्प्लोइमेन्ट, गरिबी सबै। तर उता जानको निम्ति उताबाट पुल फ्याक्टर त आकर्षक हुँदै थियो भने बिचमा ट्रिगरिङ फ्याक्टर चाहिँ सोसियल मिडियाले नै खेलिरहेको थियो, टिकटकहरूले नै खेलिरहेको थियो। किनभने टिकटकमा मान्छेहरू एकदमै एक्जाजरेट किसिमका, ग्ल्यामराइज किसिमका भिडियोहरू बनाइ नै रहेका थिए। अनि यो अनसन बसेको बेलामा काठमाडौँमा मैले लिएको फोटो योहरू भनेपछि त्यसले गर्दा मान्छेहरू विभिन्न रुटबाट पुगे। अब जस्तै अब यहाँ सुरुमा चाहिँ एकदमै धेरै जस्तै एउटा चाहिँ विद्यार्थी भनेर पढ्न भनेर नि गएका छन्। म आफै त्यहाँ भिसाको लाइनमा बस्दाखेरि अधिकांश मानिसहरू हामी टुरिस्टको लागि जान लागेको, टुरिस्ट भएर जान लागेको रस्सा भन्थे। अनि मान्छे हेर्दा टुरिस्ट भएर जाने र नजाने त हामी नेपाली त क्लास त्यो त्यसै चिनिन्छ नि, विदेशी पो दुईवटा कुरा गर्दा त्यति चिनिँदैन। हामी नेपालीहरू त अनि टुरिस्ट भएर जाने जस्तो त देखिँदैन भनेर कुरा गर्दै जाँदा सबैजना टुरिस्ट भन्दै जाने। तर के त उनीहरू अनि पछि मैले गफ गर्दै गइसकेपछि टुरिस्ट होइन रहेछ, आखिर वारमै जान लागेको रहेछ। तर यहाँ भिसाको लाइनमा बस्दाखेरि चाहिँ टुरिस्टै भनेर चाहिँ लाइन बसिरहेको थिएँ। त्यसले गर्दाखेरि अब कति केसहरूमा चाहिँ यो हेर्दाखेरि चाहिँ कस्तो छ भने यो क्लासिकल न्यारेटिभ जस्तो गरेर थाहा नै नपाइकन इनोसेन्टली गयो, झुक्काएर लग्यो, एजेन्टलाई लग्यो भन्ने मात्रै क्लासिकल न्यारेटिभ छैन। यहाँ केही फरक कुराहरू के छ भने आर्मीमा जागिर खाएको मान्छेहरू पनि गएको छन्, पुलिसमा जागिर खाएको मान्छेहरू पनि गएको छन्, युए पुगेर राम्रै कमाएको मान्छे पनि गएको छन्, र चाहिँ नि पहिला कलेज जोइन हुनु भनेर कलेज पढ्न एमबिबिएस पढ्न भनेर गएको मान्छे अनि आर्मीमा युद्ध लड्न पनि गएको छ भनेपछि अहिले हामीले के हेर्नु पऱ्यो भने वार न्यारेटिभहरू चाहिँ पहिला जस्तो पुरानो हामीले सिरियल टेलिसिरियलमा हेरे जस्तो एउटा दलाल गाउँमा जान्छ र एउटा निर्दोष महिलालाई फकाएर बम्बई पुर्याउँछ भन्ने न्यारेटिभ एउटा ट्रेडिसनल भयो। अब अहिले सबै यस्ता किसिमका न्यारेटिभहरू चाहे ह्युमन ट्राफिकिङमा होस् चाहे यो किसिमको सर्डी ट्राफिकिङमा होस् अहिले चेन्ज भएर गएको छ। कति ठाउँमा चाहिँ लार्जर थ्योरिटिकल इन्टरप्रिटेसन गर्दा त त्यो स्ट्रक्चरल इस्यु नै हो, तर इन्डिभिजुअल आफै एजेन्सी आफै पनि त्यहाँ जानलाई धेरै कसरत गरेको देखिन्छ। यो अब पोस्ट डेथ राइट जस्तै अब विभिन्न चिजहरू अब जस्तै गए मान्छे मृत्यु भयो ल्याउन गाह्रो भयो। जस्तै अब अहिले धेरैजनाको चाहिँ अब अहिले म पछि पनि भन्छु यो मिसिङ स्ट्याटस पनि छ, हराएको स्ट्याटस पनि छ। त्यो फोरेन्सिक ह्युमेनिटेरियनको पोइन्ट अफ भ्यूबाट डेड बडी ल्याउन गाह्रो भइरहेछ। तर कति केस चाहिँ अब हराएपछि के गर्ने त भन्दा मृत्युको खबर आएपछि नेपाली कल्चर अनुसार यो कुसको चाहिँ नि डेड बडी बनाएर जलाउनेदेखि लिएर यस्तो घाँसको यो परालको डमी बनाएर जलाउनेदेखि लिएर यस्ता किसिमको डेथ राइट्सहरू पनि मान्छेहरूले गरिरहेको देखियो। अब विभिन्न किसिमको क्लासिकल न्यारेटिभकै कुराहरू गर्दाखेरि चाहिँ अब यो ठ्याक्कै यहाँनिर मैले यो 190 इन्जर्ड फाइटर्स र 300 पिपल आर स्टिल अननोन भने चाहिँ एक्चुअल डेटा चाहिँ कसलाई पनि थाहा छैन। रसियनतिरको न्युज हेऱ्यो भने पनि एक किसिमको छ, युक्रेन न्युज हेऱ्यो भने एक किसिमको छ, नेपाली न्युज एक किसिमको छ, नेपालको परराष्ट्र मन्त्रालयले भनेको न्युज अहिले म एकछिनपछि देखाउँछु। तर इन्जर्डहरू पनि त्यति नै छन् होइन, तर एक्चुअल डेटा चाहिँ त्यो नै थाहा पाएको छैन। अब अलिकति के भयो अब यस्तै जस्तै मेरो पिएचडीमा मैले माओइस्ट वारमा रिसर्च गरेको थिएँ। माओइस्ट वार सिद्धिएको 10औं वर्ष 15 वर्षपछि पनि गोली लिएर बाँच्ने मान्छेहरू धेरै थिए नेपालमा। अहिले यो पनि ठ्याक्कै त्यस्तै किसिमको सिमिलर किसिमको प्याटर्नहरू सुरु भएको छ। मेटल फ्रेगमेन्टहरू लिएर बरिड लेगहरू लिएर थुप्रै किसिमको यसमा सुरु भएको छ। अब लास्टमा जस्तै एकजना मानिस चाहिँ मृत्यु भयो भन्ने भइसकेपछि खबर आइसकेपछि अनि उसको चाहिँ फेरि नेपालमा आएर घिउ दलेर अनि फेरि गोइसरीमा गएर फेरि रिम्यारिज गरेर त्यो क्रिया बस्दा क्रिया रोकेर त्यसरी शुद्ध फिर्ता भएको चाहिँ कुराहरू त्यो इस्यु न्यारेटिभहरू छ भने अन्तिममा मैले भन्नुपर्दा अब यो यसरी गइसकेपछि परिवारमा पनि फ्रेगमेन्टेसन आयो, अनेक किसिमका सेपरेसनहरू आयो, अनेक किसिमका सोसल सफरिङहरू भयो, अझ पनि मान्छे मिसिङ छन्, अझ पनि इन्जर्ड छन्, अझ पनि घाइते छन्। यसले गर्दा अफकोर्स हाम्रो यो सेसनको थिमलाई रिलेट गर्नुपर्दा हामीले मेन्टल हेल्थका विभिन्न किसिमका इस्युहरू त यो कम्युनिटीमा यो पपुलेसनमा यो रेस्पोन्डेन्ट ग्रुपमा छ भन्ने कुरा हामीले विश्वास गर्नु परिहाल्यो। यो तर रिसर्च त्यो रिगरस प्रिभ्यालेन्स स्टडी अथवा कुनै पनि किसिमको साइन्टिफिक स्टडी यो हामीले यस्तो किसिमको एन्थ्रोपोलोजिकल स्टडी गरेको बाहेक यस्तो किसिमको स्टडी यो ग्रुपमा भएको छैन। यो हामी लास्टमा म यो भनेर मेरो लास्ट स्लाइड हो। प्राइम मिनिस्टर प्रचण्ड भएको बेलामा हामी डेलिगेसन गएको थियौँ हाम्रो ग्रुप यो सबै भिक्टिमहरूको फ्यामिली सहित सबैजना। अनि उहाँले चाहिँ म आफै सेन्ट पिटर्सबर्ग गएर म आफै चाहिँ नि पुटिनसँग मिटिङ गरेर यो कुरा सल्टाउँछु भन्नुहुन्थ्यो। त्यो भने 2-3 हप्तामा 2-3 हप्तामा उहाँ हुनुभयो। त्यसले गर्दा उहाँ त्यो पनि एउटा इन्ट्रेस्टिङ छ क्या अनि होइन। त्यसले गर्दाखेरि यो एउटा इस्यु अब अहिले पछिल्लो समय विगत 1 वर्षदेखि इन्टरनेसनल मिडिया कसैलाई इन्ट्रेस्ट छैन यसमा। नेपाली चाहिँ नि युट्युबमा पनि पपआउट हुन छोडिसक्यो, यो सोसल मिडियामा यो इस्युहरू आउनु छोडिसक्यो। एकदमै झिना मसिना इस्युहरू आइरहेछ। परराष्ट्र मन्त्रालयको रेकर्ड अनुसार चाहिँ 118 नेपाली किल भएको छ, मतलब मृत्यु भएको छ, 132 जना अझै मिसिङ छन् भने 219 जना चाहिँ रिपोर्टेड इन्जर्ड भएको छन्। तर अब यो न इन्जर्डहरूलाई स्पेसल स्किम छ न त मिसिङ खोज्ने स्पेसल मिसन छ। र अब यो किलिङहरूलाई त अब अहिले आकर्षक प्याकेजले अलिकति केही दिने भने त भनेको छ, तर त्यो दिनेले केही मान्छेहरूमा इमोसनल उता आएको छ, के भन्छ कस्तो हुँदो रहेछ भने के मान्छेहरूले कस्तो लक्षण देखाउन थाल्यो भनेर आएर एक्टिभिस्टले भन्नुभयो भने अब यो हस्बेन्ड नभेट्यो भने राम्रै हुन्छ, किनभने भेटेन भने कमसेकम रसियन गभर्मेन्टको प्याकेज त इन्जोय गर्न पाइन्छ भन्ने खालको साइकोलोजी चाहिँ देखाइरहेका छन् भनेर अब क्लासिकल न्यारेटिभले के भन्छ। थ्याङ्क यू सर, टाइम मिलोस्।
Thank you very much, Dr. Sachin. It was a very comprehensive presentation. अब यो टाइम धेरै नभएकोलाई यसमा क्वेसन एन्सरको हामीले दिन सक्दैनौँ अहिले, बरु पछि एउटा क्वेरी तपाईँको सुन्दा सुन्दै चाहिँ हामीलाई के लाग्यो भने इन्स्पाइट अफ यो सबै यत्रो खतराहरू हुँदाहुँदै पनि किन गइरहेछन् नेपालीहरू भन्ने चाहिँ त्यति साह्रो आएन जस्तो लाग्छ। के त्यस्तो एट्र्याक्सन हो होइन जसले गर्दाखेरि चाहिँ उनीहरू गयो भन्ने कुरा, त्यो चाहिँ हामी पछि छलफल गरौँला।
I would love to answer this query. Thank you, sir.
Now, the third speaker is Dr. Pushparaj Paudel, and he will be delivering his thoughts about securing the future, implementing Nepal's self-financing strategy 2080-2090, so for a 10-year strategy. And he is the Section Chief in Policy Planning Division at the Ministry of Health and Population. Of course, he has been involved in many high levels, health governance, strategic planning, and the monitoring of national health programs. So, I invite him. Is he here, the speaker? No, he was there when he was. Oh, okay. So, should you wait for him or should I? Okay. Oh no. Okay. That's true. All right, if he's here. Okay, your turn. Yeah, please. Dr. Pushparaj Paudel. Okay.
Namaskar and very good morning to you all. Respected chiefs, very distinguished leaders over here. So I'm Pushparaj Paudel. I currently work in Ministry of Health and Population in Policy, Planning and Monitoring Division. So my today's topic is not new. Just I would like to highlight these topics over here because as we are now in the verge of some financial cuts, some paradigm shifting in the financing models in the world, regions and country as well. So let me go with the policies and the strategies that we have in our place and existing in the health system. So why I choose my topics as ensuring the future with implementing the national health financing strategy. So we know that we do have a very background scenario. Currently, we are in a phase of LDC graduations. Similarly, the new government has promised that the new governments will lead the country by within 10 years with personal income of $3,000, and now we are in the life expectancy age of 72 years, and now again the government or the priorities of the government is to strengthen to increase the life expectancy. So with this, a very promising the backgrounds and commitments led by the new governments. So we face some sort of issues, challenges, and we do have some constraints. So there is a background that there is a signatory of the universal health coverage, the commitment of the world, and the leaders or the doers in the primary health care works and in the reimagining PSC models. So these are the backgrounds that the nation is carrying ahead. So with this, the background, the government of Nepal has approved the National Health Financing Strategy 2023 to 2033 with the aim of that the government will secure the health of our citizens, that has enacted in the Public Health Service Act, that has mandated in the constitutions and aligned with government policies. So we know that the vision is simple, making our people healthy and making the country prosperous. So with that, the goals, and there are the 5 strategic objectives that is put forwarded in the National Health Financing Strategy. The first and the foremost and the very priority one is to ensure the availability of financial resource for health services. If we are going to analyze these strategy objectives, see, we have seen some sort of increment during the pandemic era, that the government has allocated around 7% of total budget in health sectors. But now see the very common trend, and the ratio is it's around sometimes below 5 and sometimes above 5. So did this financial space, did this financial resources ensure our peoples with a good health? So of course there is a challenges. And the second is to reduce the financial risk of citizens in health service and ensure the easy access to necessary health services. Yeah, we know there are very big discussions on the social financial health protection schemes and social health programs of governments. Still, they are there in the place that we are facing a very harsh condition in ensuring the financial health, risk protection of our citizens while taking the health services. So these are the glimpses of the current health systems that we have in a place. And see, if you see the very numerical data, yeah, you can see there's some incremental graph over here, but they are not incremental graph in the total budget of the country. But see, if you see in this, the health budget, not working this. So it is always below in the bottom. So as I already mentioned that we are near around 5% of the total budget. So if you see the PSC, but the constitution has mandated as a BHS, basic health services. So this is other way, it is none other than PSC. So if you see in the PSC, the government has allocated its आफै चलिरहेछ कि क्या हो यो बरु कतैवटा गर्नु त. So if you see in the हैन यो त थाहा छ तर आफै चलिरहेछ कि. My works.
No, actually, मलाई देखाउनुस् त कसरी.
यो यही हो. Yes, next. So these are the graphical data and presentation that we have in a GHED actually, the global health expenditure data. And it shows that there is a current health expenditure from government sectors and the private sector and external sector in the very first row. And the second, there is a non-PSC in the expenditure made by the government is 29%, whereas by private is 68%. That means the people goes for private health institution for specialist care, we do guess. And in the primary health care, that is actually the mandated by constitution and enacted by the act, where the government has the made expenditure of around 33%, whereas private. So again, we are forcing our people to go the private. That the 57% of the expenditure, that shows this big data. That means we have not reached to the peoples. There are areas or there are lacunas where we are still unreached. So this signifies that. Next. So there are the health system needs, the gaps, and the government or the peoples need to address that. But if you see in the financial the allocation, the allocative efficiency, the technical efficiency, and the whole the structure of the budget. See, the 94% of the budget is contributed by the government sectors, and where the 6% is by the non-government, that is the health development partners, what we can say the EDPs, external development partners, the 6%. And again, if you disintegrate this 6% data into further, the 48% is by the loan, and sorry, 48% is the grant, and the 52% is the loan. So that shows that there is a huge gaps, and there is a trends that the source from the external development partners and non-government sources is decreasing, and it shows that the government needs to go ahead, need to allocate more from its wallet. Next. Next, please. And again, if you see the budget of whole government in the different tier of government, in the locals, federals, and provincial, yeah, there is significant budget allocation in the local, and there is a huge in the federal, and the very minimum in the provincial level in 2024 to 2025. And this is the trend showing that this is almost the same trend is in our place. And this is the national health financing strategy that has action policies, strategies, goals, and vision that I already mentioned in my previous slides. And there are some very deliverables and doable action policies that not only the government need to know, all the citizens, all the policy enablers, policy actors, and all stakeholders must to know. And this must to start in the academia, university, and civil societies. That is, yeah, the government has promised in the national health financing strategy that it will be allocate 10% of the total budget, but it's not happening till that. We are very struggling, and we are very fighting for the allocation. And the second is, some economists says that we are in the double burden of economic challenges. That is, one, the allocation is also the inefficient or insufficient, and if you see the technical efficiency, that the consumption of the budget, there is also that inefficiency. That is allocative insufficiency and technical insufficiency. These two, sometimes some economists says that there is a double burden of economics in the health sector, not in the health sector, government sector as well. So the very must, sometimes very a high sounding word, CBLP, central bidding and local processing. We are listening these terms from decade, and it's not happening that. And we hope that if you apply that this CBLP from the central level, yeah.
You will have 1 more minute because of those, interruption.
May I request our honorable chairs to give me some extra times?
I've given you 1 minute. No?
Yeah.
Okay.
So actually, there are 5 strategies, policies that I already mentioned in here. So we all, not only the government sectors, we all stakeholders, we all policy enablers, policy regulators must to adhere with the strategic policies here for ensuring our people's the health. In the strategies number 1, there are the 4 policy actions, and the policy action is just to increase the fiscal space of our budget. So we have a limited source. We need to look forward for the fiscal space exploration. And the second is strengthen the health finance governance through the efficient management by making investment in the health responsible, accountable, and transparent. That I already mentioned. It needs the strengthening, the capacity strengthening of the leaders, of our organization, of our sectors, of our all level of the governments. There are the 13 policy actions that is envisioned in the strategy number 2. starting from the budget allocation to the expenditure monitoring, evaluation, and auditing and evaluation of our policies. And the strategy number 3, mobilizing resources for quality public health service delivery and ensuring health insurance coverage for service users in line with the concept of social health security. Yes, we are allocating the fund for social health security. If you see in the data, the demand side from the providers is very increasing. And if you see the data on USC coverage, we very hardly reach to the 54% of USC index achievements. And if you see the population number, only hardly the 90 lakhs people have been enrolled in the health insurance program. So with this middle journey, the stakeholders, the policy, the planners are facing very difficulty in managing resource and mobilizing resource in the public health service delivery. So in the strategy number 4, manage resource for basic health care on per unit basis based on population, geography, and disease burden. That is none other than equity basis. Yeah, sometimes there are chaos, sometimes there are the blames, blamings comes from the public society that the budget goes to the some areas only. So this is also very carefully evaluated and allocated as per the needs and with the address of the equity basis. And similarly 5, yes, we are facing different kinds of health emergencies, different kinds of emergencies starting from natural calamities, disasters, and all those the issues, all those major the issues that has imprints in the public health system need to be addressed with the budgets, program, fund, function, and functionaries. That is the strategy number 5. So for the implementation of this national health financing strategy, we have placed the federal committees in the central government and the provincial committee in the province and the local health committee in the local governments, comprising of the very powerful stakeholders that has a very powerful role on the allocating budgets, implementing budget, and evaluation of the program. Within a minute, I will wrap up my presentation, sir. So there are the monitoring and evaluation frameworks envisioned in the national health financing strategies. We all sectors go through this. We all sectors need to have a very pinpoint analysis on this, the result monitoring framework, so that only we can reach to the goal, so that we can ensure the futures of our people's health in their place.
Thank you very much. है तपाईलाई धेरै धन्यवाद छ यो हामीसँग धेरै पेपरहरु छ अहिले गर्नुपर्ने I have already given you more than 3 minutes.
Thank you, sir. Thank you.
यो एकदमै महत्त्वपूर्ण उहाँले यति धेरै भन्न खोजिराख्नु भएको थियो यसको लागि चाहिँ छुट्टै एउटा सेसन चाहिन्छ हगे र मेरो धेरै क्वेशन्सहरु पनि थियो तपाईको यसको बारेमा तपाई बस्दै हुनुहुन्छ हैन यो सेसनसम्म अन्तिम कस्तो खालको बनाएको त बट एनीवे पछि फर्केर आउनु यतातिर अनि हामी छलफल गरौँला यसको बारेमा है त ल थ्यांक यू सो मच ओके अब now floor is yours.
Okay, let me have the pleasure of inviting Dr. Pashupati Mahat, and his paper is entitled From Design to Delivery, Exploring the Implementation of Mental Health Psychosocial Support Services through a stakeholder's perspective. Mr. Pashupati Mahat is a clinical psychology specialist and technical director of CMC Nepal. He has significant expertise in integrating mental health and psychosocial support services. So the floor is yours, Dr. Mahat.
Let me just say one thing, because what I have seen, कि हाम्रो स्पिकरहरु जहिले पनि टाइमको गाह्रो हुन्छ. So I will inform you 2 minutes before. Sure. Okay, your time is finishing, and you have to finish it with that 2 minutes extra. Thank you.
Thank you, both chairs. It's a time already good noon to all of you, and it's a very pleasure to have such August gatherings. Initially, there were few participants. I was quite worried. Now hall is full. if I borrow from first presenter, Dr. Vinita, she has already talked about the mental health scenario that builds my presentation background. So I don't need to read again about the prevalence things. The only fact I want to tell you is that this particular study has been conducted among the conflict victims. As we all know, the country underwent a decade conflicts, and that has impacted a largely huge number of the peoples. So we have focused this particular MHPSS interventions with the conflict victim, but later it has been expanded to all. And it followed the WHO's recommendation that providing comprehensive, integrated and responsive mental health and social care services within the community as recommended by WHO, and this try to follow the community mental health approach. Let me talk about the MHPSS. It's WHO's global terms, mental health and psychosocial support. This particular project, intervention project, followed MHPSS interventions, and it went for about 4 years from 2021 to 25, with the main aim supporting to conflict victims to reach their mental health and psychosocial stability, enhance their psychosocial well-being, and are able to address their undealt emotional difficulties. Conflict victims in this particular study targets are defined 3 categories conflict victims. First one is the victims who has lost their family members during the conflict, that means the family members killed, and the second is those their family member disappeared up to now and their status is not known, and third one is those conflict victims who are severely injured and are living in a debilitating step of life. So regarding the MHPSS intervention, यो चाहिँ WHO को प्राइमरी हेल्थ केयर सेटिङमा मेन्टल हेल्थ सर्भिसलाई टास्क शिफ्टिङबाट लैजाने एमएच ग्याप प्याकेज थियो र त्यो एमएच ग्याप प्याकेज नेपालको मिनिस्ट्री अफ हेल्थ नेसनल हेल्थ ट्रेनिङ सेन्टरले त्यसलाई एडप्ट स्ट्यान्डर्डाइज गरे प्याकेजमा हामीले यसमा अलि धेरै युज गरेको भनेको मोडुल 2A र B, जो चाहिँ प्रेस्क्राइबर जसले बिरामी जाँचेर औषध लेख्छन् त्यो प्याकेज कतिको रेलेभेन्ट एफिसिएन्ट छ कि छैन। अनि अर्को चाहिँ there is a module 6 which talks about the 6 month psychosocial counseling training, किनभने conflict victimलाई धेरै औषधि भन्दा काउन्सेलिङको सर्भिस निड भएको भएर हाम्रो हेल्थ वर्करले त्यो सर्भिस दिँदाखेरि आर दे रियली एबल टु सपोर्ट इफेक्टिभ सर्भिस अर नट भन्ने थियो भने ट्रेन काउन्सिलर्सहरूलाई डिप्लोइड गरेर सर्भिस प्रोभाइड गर्ने र म्यासिभली अवेरनेसको प्रोग्राम चाहिँ भेरियस मिडियाबाट चाहिँ सबै भिक्टिम्सहरू र अरूले पनि थाहा पाउन सकुन् र सर्भिस एक्सेस गर्न सकुन् र सर्भिस पोइन्ट अफ पुग्दाखेरि उनीहरूले राइट ठाउँमा सर्भिस पाइने ठाउँमा रिफरल पनि होस् भनेर त्यो खालको यो इन्टरभेन्सनले डिजाइन गरेको छ र यो स्टडीको मेन अब्जेक्टिभ चाहिँ मेन्टल हेल्थ सर्भिस चाहिँ कतिको इफेक्टिभ छ भनेर हेर्ने हो भने अब यसको अलिकति इम्प्लिमेन्टिङ साइन्स एप्रोचबाट हेरे भएर एक्सेप्टेबिलिटी, एप्रोप्रिएटनेस, एडप्सन, फिडिलिटी, फिजिबिलिटी, कस्ट, पेनिट्रेसन, सस्टेनेबिलिटीको पाटो हेरेको छ भने सर्भिस प्रोभाइडर युजरको एक्सपिरियन्स कस्तो छ र सँगसँगै चाहिँ ब्यारियर र कन्स्टेन्टहरू के छ एमएचपिएसएस सर्भिस एक्सेसमा भनेर चाहिँ यो चाहिँ स्टडी इन्टरभेन्सन प्रोभाइडेड 13 म्युनिसिपालिटिज अफ 5 डिस्ट्रिक्ट्स अफ 3 प्रोभिन्सेस। मेथडोलोजी चाहिँ यो मिक्स्ड मेथड स्टडी हो, यसले क्रस सेक्सनल र क्वालिटेटिभ दुइटै अप्रोच फलो गरेको छ र के अरे क्वान्टिटेटिभ स्टडी चाहिँ 228 सर्भिस युजर्ससँग सर्वे मेथड्सबाट गरिएको छ र त्यहाँनिर पार्टिसिपेसन र स्टिग्माको स्ट्यान्डर्ड क्वेसनआयर पनि युज गरेर डाटा लिएको छ भने क्वालिटेटिभ चाहिँ 86 ट्रान्सक्रिप्ट्सहरू प्रड्युस भएको छ आइडिआई, केआइआई र एफजिडी मार्फत भने यो स्टडीको होइन 400वटा एथिकल एप्रुभलहरू लिएको छ। अब यो ओभरअल प्रोसेस कसरी फिल्ड टेस्टिङ भयो, डाटा कसरी कलेक्सन गरियो, मोनिटरिङ सपोर्ट कस्तो छ ड्युरिङ द प्रोसेस, एथिकल एप्रुभलका कुराहरू देखाउन खोजेको छ। नाउ आई एम कमिङ टु द रिजल्ट। क्वान्टिटेटिभ रिजल्ट चाहिँ मेजोरिटी अफ द सर्भिस युजर्स 16 to 88 इयर्सको रेन्जमा छन् विथ अ मिन अफ 49.69 भने मोर देन नियरली 2/3 फिमेल पार्टिसिपेन्ट छन्, म्यारिड छन् 64%, फ्यामिली स्ट्रक्चर चाहिँ 60% भन्दा बढी न्युक्लियर छ भने फलोड बाई जोइन्ट फ्यामिली स्ट्रक्चर छ। एथनिसिटीमा हाम्रो सोसियो डेमोग्राफीको जस्तो बाहुन छेत्री हाइएस्ट छ 44%, फलोड बाई जनजाति एन्ड देन दलित। इन्ट्रेस्टिङली एभरेज मन्थली इन्कम कन्फ्लिक्ट भिक्टिम्स नियरली 20,000 छ र त्यसमध्ये उनीहरूले पर मन्थ चाहिँ 500 जति उपचारमा खर्च गर्दा रहेछन् र मेजोरिटीको अर्निङ सोर्स चाहिँ फार्मर छ भने त्यसपछिको डोमेस्टिकको छ। अब म अलिकति यो पार्टिसिपेसन कस्तो छ त मेन्टल हेल्थ प्रब्लम्स भएर उनीहरूले सोसाइटीमा पार्टिसिपेटको स्ट्याटस कस्तो छ भनेर यो 18 आइटमको स्ट्यान्डर्ड क्वेसनर युज गरेको थियो। यसमा यो रेडले देखाउनुहुन्छ भने त्यहाँ इन्डिकेटर लार्ज प्रब्लम भन्छ, यो लाइकट स्केलमा छ, र ग्रिनले नो प्रब्लम भन्छ। त्यो रेड कप चाहिँ कतिपय आइटममा हाई छ भनेको ती आइटम्सहरू उनीहरूलाई पार्टिसिपेसन इज स्टिल डिफिकल्ट, तर ग्रिन आइटम्स चाहिँ धेरैमा माथि गएको चाहिँ सजिलो पनि फिल गर्दै गएको छ, यो मेबी बिकज अफ द इन्टरभेन्सन भनेर देखिन्छ। अर्को चाहिँ स्टिगमा कतिको बढाएको छ कि घटाएको छ त मेन्टल हेल्थ प्रब्लम्स भनेर हेर्दाखेरि यहाँले पिङ्क लाइन हेर्नुभयो भने स्टिगमा घटाएको देखिन्छ, नो स्टिगमा भने हुन्छ नि। येलोले चाहिँ यस भनेर देखाउँछ, तर त्यो यस भनेको आइटम 2 चाहिँ फेरि भिक्टिम्सले आफ्नो प्रब्लम चाहिँ आफूलाई विश्वास भएको मान्छेलाई सजिलै भन्न सक्ने भएको छु भने हो। सो इट हेज अ मोर पोजिटिभ साइड्स देन द नेगेटिभ वान। त्यसै गरी यो सर्भिस एक्सेप्टेन्स कस्तो छ त भनेर उहाँहरूलाई सोधिएको त्यो क्वेसन आएर छ, त्यसमा चाहिँ 94%ले एमएचपिएसएस सर्भिस चाहिँ इजिली एक्सेप्टेबल, सजिलो छ, यो स्वीकार्य छ, हेल्पफुल छ भनेर भन्नुभएको छ। अब म अलिकति क्वालिटेटिभ रिसर्चतिर आएँ। यसमा चाहिँ एक्सेप्टेबिलिटीको कुरा गर्दाखेरि सर्भिस चाहिँ त्यहाँ प्रोभाइडर र तपाईँको पोलिसी मेकर युजर दुवैले एकदमै राम्रो छ, एक्सेप्टेबल छ भनेको छ भने प्रोभाइडरमा चाहिँ ट्रेनिङले चाहिँ कन्फिडेन्स बढाएको छ डायग्नोसिस गर्न, औषध दिन भनेर हेज बिन सपोर्टेड बाई देयर भर्बाटिम्स। त्यसै गरी एप्रोप्रिएटनेस हेर्दाखेरि चाहिँ यो एमएचपिएसएस इन्टरभेन्सन कन्फ्लिक्ट भिक्टिम्स र जसलाई लङ टर्म साइकोलोजिकल सपोर्ट चाहिन्छ उनीहरूको लागि रेलेभेन्ट छ, र यो इन्टरभेन्सन चाहिँ लोकल निड्ससँग अलाइन गरिएको छ, त्यसले गर्दा कन्फ्लिक्ट भिक्टिम्स र अरूलाई पनि यसले सपोर्ट गर्छ भनेर भन्छ। भने एडप्सनको कुरा गर्दाखेरि सबै इन्टरभेन्सन चाहिँ म्युनिसिपालिटिजले त्यसको आधारमा उनीहरूको आफ्नो स्ट्राटेजी पोलिसी बनाएर काउन्सिलिङ सर्भिसलाई इयरली प्लानमा इन्क्लुड गरेर देखिन्छ भने त्यही अनुसारको चाहिँ काउन्सिलरहरूलाई पनि उहाँहरूले डिप्लोइड गर्नुभएको छ। कस्टको कुरा गर्दा अघि पनि मैले भने 12वटा एसेन्सियल मेडिसिन अलरेडी फ्री लिस्टमा छ, तरै पनि रेगुलर सप्लाईको निम्ति बजेट अलिकति च्यालेन्जिङ देखिन्छ। हेल्थ इन्सुरेन्सले रोल चाहिँ गरेको छ, तर मेन्टल हेल्थको सबै मेडिसिन त्यहाँ पनि अभाइलेबल छैन भने लोकल गभर्मेन्ट बजेट एलोकेट गर्न थाल्नु भएको छ, तर उनीहरूलाई नै जाने बजेटै थोरै भएको भएर अभियसली इट इज नट सफिसियन्ट भन्छ। फिडेलिटीको कुरा गर्दा ट्रेन हेल्थ केयर प्रोभाइडर्स चाहिँ सिकेको स्किल प्रयोग गर्न कम्पिटेन्ट देखिन्छन् भने ट्रेनिङ, रिफ्रेसर ट्रेनिङ, क्लिनिकल सुपरभिजन इज अ मस्ट टु मेन्टेन दियर नलेज एन्ड स्किल्स भनेर भन्छ। फिजिबिलिटीको कुरा गर्दा यो एमएचपिएसएस सर्भिस चाहिँ रिकग्नाइज हुँदै गएको र तल्लो तहसम्म वार्ड लेभलको हेल्थ फेसिलिटीमा पुगेको भएको भएर त्यो चाहिँ राम्रो छ, तर औषधिको सप्लाई प्रोक्युरमेन्ट च्यालेन्ज चाहिँ निड टु बी एड्रेस भन्छ भने लिडरसिपले क्रुसियल रोल प्ले गर्दछ लोकल लेभलमा। यदि लिडरसिप पोजिटिभ छ भने यो इस्यु सजिलो सर्ट आउट भएको हुन्छ। जहाँ लिडरसिपलाई अलिकति एक्सेप्ट गर्ने गाह्रो छ त्यहाँनिर समस्या छ भने पेनिट्रेसनको कुरा गर्दाखेरि अब एक्सपान्ड चाहिँ भएको छ यो इन्टरभेन्सन भएको प्रोजेक्टहरूमा, तर स्टिल चाहिँ वाइडली रिच हुनलाई च्यालेन्ज छ किनभने गभर्मेन्टको त्यही अनुसारको इन्भेस्टमेन्ट छैन। अब एउटा चाहिँ यो एमएचपिएस इन्टरभेन्सन भएको ठाउँमा चाहिँ 90% जस्तो मेन्टल हेल्थ प्रब्लम ट्रेन हेल्थ वर्करले आइडेन्टिफाई गरेर म्यानेज गर्न सकेको छ भने त्यसले त एउटा बिरामीको काठमाडौँसम्म अथवा सहरसम्म जानुपर्ने इस्यु पनि घटाइदिएको छ भने सस्टेनेबिलिटी चाहिँ यो यसले डेमोन्स्ट्रेट गर्यो कि यो सस्टेनेबिलिटी छ, ओनरसिप पनि लिन थालेको छ, तर रिसोर्स कन्स्टेन्ट इज देयर। त्यसै गरी स्केल अपमा पनि मेनली चाहिँ रिसोर्सको कुराहरू हेर्नुपर्ने छ। ब्यारियरमा चाहिँ आइएम अलमोस्ट टुवर्ड्स द एन्सर। ब्यारियरमा चाहिँ स्टिग्माले स्टिल मेन्टल हेल्थ सर्भिस लिनलाई डिफिकल्ट छ। हाम्रो जोग्राफी अनि लजिस्टिक रिसोर्सेस अबाउट दि साइकोट्रोपिक मेडिसिन सप्लाई, वर्क फोर्स एभाइलेबिलिटी, bureaucratic process of a purchase, work burden to the health workers, that all plays to some extent barrier भने फेसिलिटेटिङमा चाहिँ कम्युनिटीको इन्गेजमेन्ट छ, इन्ट्रेस्ट छ, भिक्टिम्सहरू आफै सर्भिस लिन आएछन्, त्यहाँनिर इम्प्याथेटिक एप्रोच भएको सर्भिस प्रोभाइडरहरू छन् भने ट्रेनिङ क्यापासिटी र सुपरभिजन त्यसले गर्दा उनीहरूलाई रेस्पोन्सिभ बनाएको छ, त्यो चाहिँ राम्रो छ भन्छ। अब इन कन्क्लुजन इन्टरभेन्सन्स एप्रोप्रिएट वेल रिसिभ्ड इन द गिभन सर्जिङ मेन्टल हेल्थ बर्डन यस्तो बढी बाटामा सस्टेनेबिलिटी स्केलेबिलिटी is limited particularly because of the financial constraint, human resource constraint and logistic constraint. यसलाई इन्टिग्रेसन चाहिँ पिएचसीमा लान सकिन्छ, तर इन्फ्रास्ट्रक्चरले पनि धेरै सपोर्ट गरेर देखिन्छ, तर अब रेगुलरली अनगोइङ फन्डिङ चाहियो, सुपरभिजन चाहियो, मोनिटरिङ चाहियो, द्याट मेक्स द सक्सेस। यो चाहिँ हामीले एडप्ट गरेको है यो टुलमा, किनभने तपाईँलाई कति सहमत हुनुहुन्छ भनेर यो फिङ्गर देख्ने बित्तिकै चाहिँ उनीहरू सजिलो म जस्तो पाँचै औँला देखाएर म पूर्ण सहमत छु आइटममा, होइन भने एउटाले चाहिँ सहमत छैन भन्ने यो चाहिँ इजिली रेटेड हो। नत्र हाम्रो त्यहाँ त्यो लाइक आर्टिसियलमा पूर्ण सहमत असहमत भनेर सोधिराख्दाखेरि इट मेक्स भेरी हार्ड फर देम। थ्याङ्क यू।
थ्याङ्क यू भेरी मच। अब हाम्रो यो अर्गनाइजरहरूलाई पनि केही भन्नुपर्छ जस्तो छ। देयर आर सो मेनी इन्ट्रेस्टिङ पेपर्स होइन, हामीले डिस्कसनको लागि टाइमै पाएको छैन, इट्स सो टाइट। आइएम सरी। अब यसलाई के गरौँला भने यदि समय भयो भने प्रोभाब्ली इमिडिएटली आफ्टर दिस जीवन घिमिरेको रहेछ, त्यहाँ अलिकति समय बच्यो भने यो मेन्टल हेल्थ सम्बन्धी केही क्वेसन्सहरू इन्टरेक्सन गरौँला। सो इफ यु I'll invite Jeevan Ghimire, which implementation challenge of Nepal's National Mental Health Strategy 2020-2025. If you can squeeze your presentation so that we can have some time for discussion also, okay? So we will inform you around 3 minutes before, so that you have ample chance to have, few questions also to answer. Thank you.
So I would go in Nepali language because to whom we discussed during this study and collected the information from them so that I could able to justice them. राम्रोसँग एक्सप्लेन गर्न सक्छु होला भनेर र टाइम पनि मलाई म्यानेज गर्न सजिलो हुन्छ भन्ने लाग्छ। ओके, थ्याङ्क यू। यो चाहिँ हामीले यो नेसनल मेन्टल हेल्थ स्ट्राटेजी नेपाल गभर्मेन्ट मिनिस्ट्री अफ हेल्थ एन्ड पपुलेसनले 2020मा बनाएको 2020 to 2025 5 इयर्सको लागि बनाएको रहेछ र यसको के प्रोग्रेस भयो, के च्यालेन्जेसहरू छ भनेर हामीले एउटा ऱ्यापिड स्टडी गरेको थियौँ। त्यसको फाइन्डिङ्स चाहिँ मैले सेयर गर्न खोजेको। यसले काम गरिरहेको छैन? ओके, अनि यो चाहिँ हाम्रो जोइन्ट स्टडी हो कि कोसिस अघि प्रोफेसर मास्केले भन्नुभयो, कोसिस र अनि हामी इडिसिडी र हामी इन्डिपेन्डेन्ट कन्सल्टेन्ट यो जोइन्ट स्टडी हो। तल हो ए ओके। अब ब्याकग्राउन्ड धेरै सेट भइसकेको छ। अगाडिको डाक्टर विनितादेखि डाक्टर पशुपतिले प्रेजेन्ट गर्नुभयो, त्यो भएको भएर धेरै ब्याकग्राउन्ड सेट भइसकेको हुनाले म धेरै ब्याकग्राउन्डमा जान्न। तर त्यो जुन 2020मा भएको मेन्टल हेल्थ सर्वेको डेटा र अरू क्वालिटेटिभ निडलाई चाहिँ एड्रेस गर्नलाई नेसनल मेन्टल हेल्थ स्ट्राटेजी चाहिँ मिनिस्ट्री अफ हेल्थले डेभलप गरेको थियो र ग्लोबल्ली यो इस्यु हो, यो बर्डन छ, हामी सबैलाई थाहा भएकै विषय हो। र अब यो स्ट्राटेजी एसेसमेन्टको अब्जेक्टिभ के थियो भन्दाखेरि चाहिँ यसको प्रोग्रेस के भएको छ त्यो हेर्नुपर्ने थियो हामीले र केही च्यालेन्जेस अनि ब्यारियर्सहरू के भयो त इम्प्लिमेन्टेसनमा भन्ने कुरा हामीले हेरेका थियौँ र केही इन्साइट्सहरू अनि वे फरवर्ड फर द फ्युचर त्यो पनि हामीले चाहिँ क्विकली कलेक्ट गर्ने कोसिस गरेका थियौँ। यो क्वालिटेटिभ डोमिनेटेड मेथोडोलोजी मिक्स्ड मेथडमा गरेको हामीले चाहिँ लगभग 155 पार्टिसिपेन्ट्सहरू जो चाहिँ केयर गिभर्स लाइभ एक्सपिरियन्स भएको पर्सन्स विथ मेन्टल इलनेस अथवा मेन्टल इस्युज उहाँहरूसँग पनि कुरा गरेका थियौँ। त्यस्तै 10वटा डिस्ट्रिक्टको हेल्थ फेसिलिटिज लोकल गभर्मेन्ट र प्रोभिन्सियल गभर्मेन्ट गरेर 7वटा प्रोभिन्समा हामी पुगेको। यसमा लिमिटेड रिसोर्स र टाइमको चाहिँ नि थियो, त्यो लिमिटेसन मैले पहिले भन्नै पर्छ।
मिस्टर जीवन यो स्क्रिनमा हेरेर बोलिदिनु पर्यो, त्यो जुन माइक छ नि त्यो साउन्ड चाहिँ युट्युबमा गएन अरे त्यसैले।
ओके, र स्टडी यो की रिजल्ट्स अलि पछि म डिटेलमा आउँछु, तर अहिले नै भन्नुपर्दाखेरि चाहिँ हाम्रो स्ट्राटेजी 1 मा चाहिँ इक्विटेबल एक्सेसको कुरा गर्छ, त्यसमा चाहिँ पार्सियल रुरल रिच हामीले पायौँ। त्यस्तै स्ट्राटेजी 2 मा रिसोर्स लेस देन 1% बजेट चाहिँ खर्च भएको छ मेन्टल हेल्थमा, र स्टिल स्टिगमा चाहिँ नि अब अवेरनेसको कुरा गर्दाखेरि स्टिल स्टिगमा चाहिँ नि धेरै छ। र अर्को चाहिँ नि अब अघि सरले भन्नुभयो कि सुप्रिम कोर्टले आदेश पनि गरिसकेको छ, तर डेडिकेटेड एक्ट बनाऊ र लागू गर भनेर, त्यो चाहिँ अहिलेसम्म खास प्रोग्रेस भएको देखिँदैन। अनि यो हामीले चाहिँ नि HMIS को स्ट्याटिस्टिक्सहरू कतिपय चाहिँ नि त्यति अझै पनि हामीले इम्प्रोभाइज गर्नुपर्ने देखिन्छ। यो उहाँहरूले चाहिँ हरेक चाहिँ स्ट्राटेजीको लागि टार्गेट्स गर्नुभएको थियो, बेसलाइन लिनुभएको छ र प्रोग्रेस गर्नुभएको छ। यसको केही डेटाहरू हामीलाई पाउन एकदमै गाह्रो भयो, तर पनि हामीले केही रिमार्क्स नोटहरू सहित राखेको छौँ। र यसमा एक्सेस र कभरेजको कुरा गर्दाखेरि चाहिँ सिग्निफिकेन्टली एक्सपेन्स भएको चाहिँ एक्सपान्सन भएको मेन्टल हेल्थ सर्भिस लगभग 63% इन्क्रिज भएको छ। तर समस्या कहाँनिर छ भने अलि बढी अर्बन सेन्ट्रिक भएको हो कि भन्ने हामीलाई लागेको छ, र रुरल एक्सेस चाहिँ अलिक अझै पनि कन्स्टेन्ट छ बिकज अफ दि ल्याक अफ स्टाफिङ अनि स्टक आउट अफ दि लिस्टेड फ्री मेडिसिन्स, विक रिफरल पाथवेज होइन, त्यस्तो छ। र त्यस्तै सर्भिस ट्रिटमेन्ट फोकस भयो, प्रिभेन्सन र प्रमोसन सर्भिस पनि त आउँछ होला हेल्थ सर्भिस डेलिभरीमा, इन्टायर हेल्थ सिस्टम बिल्डिङ ब्लक्सको कुरा गर्ने हो भने। सो यहाँनिर अलिकति हामीले चाहिँ ग्याप छ भन्ने पायौँ। यो अघि डाक्टर विनिताको प्रेजेन्टेसनमा पनि आयो, दुईवटा लास्ट फिस्कल इयरको हेर्दाखेरि यो सर्भिसको हिसाबले हेर्ने हो भने 1,19,000लाई ट्रिटमेन्ट हामीले दिएको छौँ, अनि 1,94,000 चाहिँ नेक्स्ट फिस्कल इयरमा ट्रिटमेन्टमा आउनु भएको छ। यो त ट्रिटमेन्टमा आएको दायरा मात्रै भयो। मेकानिजमको कुरा गर्दाखेरि र रिसोर्स वर्कफोर्सको कुरा गर्दाखेरि यो इन्डिकेटर्सहरू उहाँहरूले सेट गर्नुभएको केही एचिभ भएको छ, केही चाहिँ एचिभ भएको छैन, तर म अलि कन्साइजली प्रेजेन्ट गर्न चाहन्छु कि सेपरेट बजेट लाइन्स चाहिँ भेटिन्छ, तर बजेट कोड नै डिफाइन गरेर अगाडि बढ्नुपर्छ भन्ने लाग्छ। अघि हाम्रो पुष्प सरले प्रेजेन्ट गर्नुभयो, एटलिस्ट हेल्थलाई चाहिँ एउटा कोड लाइक 6 दिनुहुन्छ भने 6.1 मेन्टल हेल्थलाई दिनुहोस्, 6.2 चाहिँ नि अर्को मेटर्नल हेल्थ चाइल्ड हेल्थलाई दिनुहोस्, त्यो अथवा चाइल्ड हेल्थलाई 6.3 दिनुहोस्। यसरी अलिकति कोडिङ गरिदिनु भयो भने सबै प्रोभिन्स अथवा लोकल गभर्मेन्ट या फेडरल गभर्मेन्टबाट कुन सेक्टरमा कति पैसा खर्च भयो, कति पैसा एलोकेट भयो, हामीलाई अध्ययन गर्न र इम्प्लिमेन्टरहरूलाई पनि बजेट एलोकेट गर्न र इम्प्लिमेन्ट गर्न सजिलो हुन्छ भन्ने लाग्छ। त्यस्तै मेकानिजम फोकल पोइन्ट पर्सन चाहिँ नि फेडरल र प्रोभिन्समा पनि खासै छैन, तर उहाँहरूले इन्डिकेट चाहिँ गर्नुभएको छ। फेडरलमा चाहिँ अब EDCDमा एउटा सेक्सन छ, तर लोकल लेभलमा चाहिँ पाइँदैन, छैन। तर सुप्रिम कोर्टको फैसलामा चाहिँ त्यो पनि छ कि फोकल पोइन्टको व्यवस्था गर्नु भनेर। अर्को चाहिँ ट्रेनिङ स्केल अप इज इसेन्सियल। अब यो क्यापासिटी हामीले वर्कफोर्सको पनि एउटा नेपाल गभर्मेन्टले प्लान गर्नु पऱ्यो, कति हामीले मेन्टल हेल्थको सर्भिस प्रोभाइडर्सहरू प्रोडक्सन के हो, एब्जर्प्सन के हो, त्यसको चाहिँ नि व्यवस्थित प्लान गर्नु पऱ्यो र फाइनेन्सिङ गर्नुपर्ने देखिन्छ यसमा। अवेरनेस, स्टिग्मा रिडक्सन र सुसाइड, अघि डाक्टर विनिताले देखाइसक्नुभयो कि धेरै चाहिँ सुसाइडको केसहरू इन्क्रिजिङ छ हामी टार्गेटको कुरा गर्दाखेरि होइन। तर एउटा हामीलाई महसुस भएको के भयो भने यो स्कुल करिकुलममा मेन्टल हेल्थको कुरा र अलिकति इमोसन म्यानेजमेन्टको कुरा जुन पढाइ हुन्छ क्लासमा, ग्रेड 8 सम्म हेल्थ एन्ड पपुलेसन अथवा केही छ त्यहाँ कुनै एउटा टेक्स्ट बुक, त्यसमा चाहिँ पढाइन्छ। तर 9 देखि 12 सम्म जुन क्रिटिकल एज हो नि, त्यो बेलामा चाहिँ करिकुलममा कम्प्लिटली ग्याप छ। त्यहाँ कसैले मेन्टल वेलनेस, कसैले चाहिँ नि अवेरनेसको कुरा कसैले पनि गर्नेवाला छैन। ओ माई गॉड। सो स्टिग्मा अझै पनि पर्सिस्टेन्ट छ। ह्युमन राइट्स र रिहेबिलिटेसनको कुरा गरौँ, पोलिसी एटेन्सन, अब यो सुप्रिम कोर्टको कुरा गरेँ मैले, एउटा इन्टिग्रेटेड चाहिँ मेन्टल हेल्थ लेजिस्लेसन बनाएर अगाडि बढ भनेर सर्वोच्च अदालतले फैसला गरेको पनि 1 वर्ष नागिसक्यो। तर अब मिनिस्ट्री अफ हेल्थले यसमा एकदमै धेरै काम गर्नुपर्ने छ। इन्फर्मेसन सिस्टमको कुरा गर्दाखेरि अझै पनि हामीले ट्र्याकिङ र डेटा क्वालिटीलाई इम्प्रोभाइज गरेर त्यसलाई प्लानिङमा चाहिँ राम्रोसँग एप्लाई गर्नुपर्ने देखिन्छ। यो स्ट्याटिस्टिक्सको कुरा एउटा पुलिसको रेकर्डबाट चाहिँ हामीले लिएको हो। सबै प्रोभिन्समा गएको 3 आर्थिक वर्षको हामीले स्ट्याटिस्टिक्स लिँदाखेरि सुसाइडको रेट कहीँ कहीँ घट्दो होला, त्यो पनि नट सो मच सिग्निफिकेन्टली, उस्तै उस्तै स्ट्याग्नेन्ट अथवा बढ्दो क्रममा छ हो कि। र टार्गेटको कुरा गऱ्यौँ हामीले, अघि टार्गेटको कुरा डाक्टर विनयताले पनि गर्नुभयो, 4.7 बाई 2030 ल्याउनु पर्नेमा अहिले हाम्रो चाहिँ करेन्ट हेर्ने हो भने 24.5 सुसाइडको जुन रेट छ पर लाखमा। यो जति केसहरू आइरहेको छ हामीलाई लाग्छ सर्भिसमा आएको सुसाइडको रेटहरू अथवा सर्भिसमा आएको नम्बर छ, यो चाहिँ टिप अफ द आइसबर्ग मात्रै हो। यसलाई हामीले एकदमै केयरफुल्ली इन्टरभेन्सन गर्नुपर्ने देखिन्छ। स्ट्रेन्थको कुरा मैले अलमोस्ट कभर गरेँ, तर एउटा चाहिँ ग्रेड 8 सम्म चाहिँ फेरि ग्रेड 4 to 8 सम्म चाहिँ राम्रोसँग त्यो हेल्थ जुन सब्जेक्ट छ त्यसमा कभर गरेछ। त्योभन्दा बढी जति माथि गर्नुपर्ने त्यो चाहिँ ल्याकिङ छ। अब कन्क्लुजनमा आउँदाखेरि चाहिँ हेल्थ प्रमोसन, मेन्टल हेल्थ प्रमोसन, मेन्टल हेल्थ प्रमोसन, मेन्टल हेल्थ प्रमोसन, प्रमोसन इन्टरपर्सनल कम्युनिकेसन गर्नु पर्यो। घर घरमा पुगेर हुन्छ कि अथवा स्कुल थ्रु हुन्छ कि युथ मोबिलाइज गरेर हुन्छ कि हामीले रिच आउट गर्नै पर्छ कि उहाँको स्टेट मेन्टल स्टेट के छ अहिले भनेर, मेरो मेन्टल स्टेट के हो भनेर मैले कुन टुल युज गर्दाखेरि थाहा पाउँछु र म कहाँ जाने, यो कुरा चाहिँ हामीले दिनुपर्छ। अब हामीले सोर्समा काम गर्दैनौँ भनेदेखि हामी सर्भिस मात्रै ओरिएन्ट भएर चाहिँ नि हुँदैन। म सकिहाल्छु डाक्टर, अब धेरै बाँकी छैन। र नेसन वाइड एमएचपिएसएस प्रमोसनको क्याम्पेन गर्नु पऱ्यो। यो म्यासिभ र बेसिक स्ट्रेस कसरी म्यानेज गर्ने, मैले इमोसन कसरी म्यानेज गर्ने भन्ने कुरा हामीले इन्डिभिजुअललाई सिकाउनुपर्छ र लाइफ साइकल एप्रोचमा हामी जानुपर्छ। बच्चा जन्मेदेखिको वृद्ध अवस्थासम्म लाइफ साइकल एप्रोचमा हामी जानुपर्छ। अघि हाम्रो सरले, घिमिरे सरले भन्नुभयो कि त्यो वारमा जानुको कारण के हो, अथवा त्यहाँ जाँदा अथवा नआउँदा खालि पैसै कमाउनको लागि पनि त गएका छन्, कति मोटिभ त्यो हुनसक्छ। त्यसो भएको हुनाले लाइफ साइकल एप्रोचमा जानै पर्छ। अनि यो मैले भने सेल्फ एसेसमेन्ट र स्क्रिनिङको टुल चाहिँ हामीले प्रयोग गर्न पर्यो। कम्पलसरी ग्रेडमा त्यो कोर्समा चाहिँ इनबिल्ड गरौँ र अरू सर्भिससँग पनि हामीले चाहिँ नि इन्टिग्रेट गर्नुपर्छ। हेल्थ इन्सुरेन्समा पनि यो मेडिकल सप्लाइज मेडिसिनको एभाइलेबिलिटी चाहिँ नि उपलब्ध हुनुपर्छ। 4500 रुपियाँसम्म महिनाको खर्च गर्नुभएको छ उहाँहरूले आफ्नो ट्रिटमेन्टमा। र यो चाहिँ हेल्थ सेक्टरको मात्रै रेस्पोन्सिबिलिटी होइन, त्यसैले मल्टी सेक्टरल चाहिँ मेन्टल हेल्थ स्ट्राटेजी बन्नुपर्छ अबको दिनमा। र मिनिस्ट्री अफ हेल्थ एन्ड पपुलेसनले भोलि पनि एउटा राख्नु भएको छ डायलग, त्यहाँ पनि म प्रेजेन्ट गर्नुपर्ने छ। त्यसैले त्यहाँ पनि हामी चाहिँ यो अगाडि बढ्छौँ। र मैले अरू थोरै 30 सेकेन्डमा सिद्ध्याउँछु कि हाम्रो अहिलेको नट ओन्ली फर मेन्टल हेल्थ सर्भिस, अदर सर्भिसको लागि पनि हामीले हेर्दाखेरि हामी क्लिनिकल मेडिकल फोकस्ड भएकै हो। यो पिरामिडमा काम गरेर हुँदैन, हामी डिजायर्ड पिरामिडमा काम गर्नुपर्छ जहाँ प्रिभेन्सन र पब्लिक हेल्थ प्रमोसनको एक्टिभिटिज हुनै पर्छ। थ्याङ्क यू सर।
Thank you very much. अब कोसिस गर्दा गर्दै पनि हामीले टाइम पाएनौँ। You have finished within your time, don't worry. So तर म के भनौँ भने मलाई तपाईँको प्रेजेन्टेसन सुन्दाखेरि I had attended a global mind brain health seminar conference in Oxford University 2025 November, and I was asked to present a paper on public health perspective on mind brain health. So then after that, what happened was that they were interested to open a mind brain center of that in Nepal also. And I just want to share this news with all who are interested. When they are coming in June also, June 2026, you know. So we'll have a seminar at that time. Those people who are actively working both in clinical field and community field, they can join to form this center, okay? I just wanted to share this information with you. Now, the next one, please, can you? And also I want to say that, look, I mean, we have about 7 people left, I think. And our organizers are giving 10 minutes each. So what does that mean? About 70 minutes of that. And you have to bear with us. It will not going to finish in 1 p.m. It will take a little bit more time, but be ready mentally for that. Thank you.
Thank you, Dr. Maske. May I now request Mr. Manish Kayastha, who's going to talk about quality of life and associated factors among parents and children with autism spectrum disorder, a comparative study in Kathmandu Valley. If I may introduce Mr. Kayastha, he serves as a public health officer at Ministry of Health, Bagmati Province, is a public health researcher with masters in public health from BPKIHS.
Thank you, Cheers. The title of my study is Quality of Life and Associated Factors Among Parents of Children with Autism Spectrum Disorder. It is the comparative study which was conducted in Kathmandu Valley. Talking about autism spectrum disorder is the umbrella term for the condition of the person under which autism itself is one of the condition, and beside this Asperger's syndrome and PDD NOS also inside the autism spectrum disorder. Prevalence of autism spectrum disorder has increased globally due to increased awareness and improved diagnostic criteria. Caregivers of children with autism spectrum disorder face unique challenges, restricted family activities, time burden, and psychosocial stress. Parents of children with autism spectrum disorder demonstrate significantly higher levels of distress, anxiety, and depression compared to parents of typically developing children. This study explored quality of life of parents of children with autism spectrum disorder to help improve service systems and promote well-being of children and their parents. The study objectives are to evaluate the quality of life among parents of children below 12 years of autism spectrum disorder and compare it with parents of typically growing children. And second objective was to assess the quality of life and its associated factors among parents of children below 12 years with autism spectrum disorder in Kathmandu. The methodology was the comparative cross-sectional study in Kathmandu Valley. The sample size was 128. Sampling technique was purposive sampling technique. And the dependent variable was quality of life itself, and independent variables were socio-demographic factors and child characteristics like age of child, sex of child, and severity of autism spectrum disorder. For the data collection tool, WHO QOL quality of life brief tool was used, and data collection technique for structured questionnaire was used, and the data was analyzed as the by the using SPSS version 26.0. Analytical methods were descriptive, bivariate analysis, multiple linear regression. Talking about the results, the most of the parents were aged 35 to 44 years, and the education level of the both groups were as similar, quite similar. And the family income, sorry ma'am, can I interrupt? I'm feeling unwell right now. I will go to washroom. Okay. Okay. We'll get the next speaker. Yeah. Yeah, it is. Only volleyball. Fresh volleyball. Let's see what you say.
Let's not waste time. Let's get the next speaker in that case. The next speaker is Pushkar Raj Podel, and he's going to talk on leveraging community health workers driven longitudinal care to strengthen primary health care and universal health coverage, early insights from community-based integrated mental health and NCD interventions. If I may introduce our speaker. Just a minute. Mr. Podel is an implementational research coordinator at Possible. Pushkar holds a master's degree in sociology from Tribhuvan University. He has extensive experience in community-based research projects, including randomized controlled trials, especially in the area of non-communicable diseases and mental health, maternal child health, nutrition, and tuberculosis. So the floor is yours, Pushkarji.
Thank you, Chair. नमस्ते सबैजनालाई मेरो नाम पुष्कराज पौडेल चेयरले इन्ट्रोडक्सन गरिसक्नु भएको छ र म चाहिँ आज पोसिबललाई रिप्रेजेन्ट गर्दैछु र हामीले गरेको एउटा वर्क एउटा ट्रायल जो छ चन्द्रगिरी र बर्दिवासमा त्यसको चाहिँ एउटा अलिकति इन्साइटहरू अर्ली इन्साइटहरू चाहिँ आज सेयर गर्दैछु यो चाहिँ अनगोइङ ट्रायल रहेको छ र हाम्रो टपिक रहेको छ आज सेयर गर्ने लिभरेजिङ कम्युनिटी हेल्थ वर्कर driven longitudinal care to strengthen primary health care and universal health coverage. जुन चाहिँ early insight from community-based integrated mental health and NCD intervention in Nepal. तपाईहरूले चाहिँ यहाँ हाम्रो को राइटर र सिनियर राइटर अथरहरूको पनि नेम लिस्टहरू हेर्न सक्नुहुन्छ. ब्याकग्राउन्डको कुरा गर्दा अघि पनि हामीले धेरै कुराहरू छलफल गरिसकेका छौँ अगाडिको प्रेजेन्टरहरूमा पनि आएको छ कि यो कमन मेन्टल हेल्थ कन्डिसन र यसमा चाहिँ विशेष गरी एन्जाइटी र डिप्रेसन अनि नन कम्युनिकेबल डिजिजमा चाहिँ हाइपरटेन्सन र डायबिटिजको कोमोबिड चाहिँ हाम्रो जस्तो देशमा चाहिँ दिनादिन बढिरहेको भन्ने पनि आएको छ र हामीले WHO को इस्टिमेट हेर्ने हो भने पनि 18% देखेको छ. यो ब्याकग्राउन्ड छ. त्यो सँगसँगै बिहेभियर इन्टरभेन्सन स्ट्राटेजीहरूको चाहिँ अलिकति युनिट चाहिँ इफेक्टिभ छ तर चाहिँ हामी कहाँ सबैको एक्सेसमा रहेको छैन. यो कन्टेक्स्ट रहेको छ र रियालिटी हेर्ने हो भने अघि नै पनि हामीले छलफल गरेका छौँ हेल्थ फेसिलिटी लेभलमा चाहिँ यसको ट्रिटमेन्टहरू अभाइलेबल छ तर कम्युनिटी लेभलमा कम्युनिटीमै गएर हाउसहोल्डमै गएर चाहिँ यसको इन्टरभेन्सनहरू अथवा ट्रिटमेन्ट फेसिलिटीहरू चाहिँ त्यति धेरै रहेको छैन. र यी ग्यापहरूलाई चाहिँ एड्रेस गर्नको लागि हामीले त अब इनोभेसन केही न केही गर्नुपर्छ भन्ने सन्दर्भमा चाहिँ हामीले एउटा प्याकेज डेभलप गरेका थियौँ जुन चाहिँ बिहेभियर इन्टरभेन्सन प्याकेज हो जसमा चाहिँ 3वटा कम्पोनेन्टहरू जसको पछि पनि छलफल गर्छु एभिडेन्स बेस्ड स्ट्रेस रिडक्सनको अनि बिहेभियर एक्टिभेसन र मोटिभेसनल इन्टरभ्यूको एउटा प्याकेज जसलाई चाहिँ हामी बिकम इन्टरभेन्सन भनेर भनिरहेका छौँ. त्यो चाहिँ हामीले इम्प्लिमेन्ट गरेका थियौँ. त्यो भनेको चाहिँ कम्युनिटी हेल्थ वर्कर्स उहाँहरू सिएचएन हुन्छ कम्युनिटी हेल्थ नर्सेस जो नेपाल सरकारको कम्युनिटी हेल्थ प्रोग्राममा काम गरिरहनु भएको छ लागू भएको केही पालिकाहरूमा र यसको टार्गेट भनेको चाहिँ हामीले CMHC र NCD को कन्डिसनलाई चाहिँ कम्युनिटी लेभलमा नै म्यानेज गर्ने हो एड्रेस गर्ने हो भन्ने चाहिँ हाम्रो टार्गेट रहेको थियो. अब यसमा CSW को कुरा गर्नुपर्दा उहाँहरू चाहिँ कम्युनिटी हेल्थ नर्स नै हुनुहुन्छ. नर्सिङ उहाँले अध्ययन गर्नुभएको र नेपाल सरकारको केही पालिकाहरूमा चाहिँ पाइलटिङ रहेको छ त्यो कम्युनिटी हेल्थ नर्सिङ प्रोग्राम उहाँ त्यसमा काम गरिरहनु भएको नर्सहरू हो कम्युनिटी हेल्थ नर्स र उहाँहरूले चाहिँ एउटा कम्युनिटी हेल्थ टुलकिट ट्याबमा चाहिँ यो टुलकिट इनबिल्ट भएको ट्याब युज गरेर चाहिँ FCHP र हेल्थ फेसिलिटी वर्कसँग चाहिँ कोअर्डिनेट गरेर चाहिँ हाम्रो सर्भिसहरू चाहिँ कम्युनिटी लेभलमा नै प्रोभाइड गरिरहनु भएको छ. बिकम अघि मैले भने बिकम इन्टरभेन्सन कुरो बिकम भनेको चाहिँ बिकम स्ट्यान्ड फर हाम्रो बिहेभियर कम्युनिटी बेस कम्बाइन्ड इन्टरभेन्सन फर मेन्टल हेल्थ एन्ड NCD को चाहिँ सर्ट हामीले चाहिँ टर्म राखेका छौँ यो बिकम भनेर. यसमा चाहिँ हाम्रो 3वटा अप्रोच रहेको छ. एभिडेन्स बेस्ड स्ट्रेस रिडक्सन जुन EBSR छ त्यो चाहिँ हामीले एन्जाइटीलाई एड्रेस गर्नको लागि चाहिँ टार्गेट गरेका छौँ भने चाहिँ डिप्रेसनको लागि चाहिँ हामीले बिहेभियर एक्टिभेसन अप्रोच अप्नाएका थियौँ अनि मोटिभेसनल इन्टरभ्यू अप्रोच चाहिँ उहाँहरूको NCDलाई चाहिँ एड्रेस गर्नको लागि गरेको छौँ. यो चाहिँ WHO ले अलरेडी प्रुभन गरेको चिज हो र यो चाहिँ हामीले कम्युनिटी लेभलमा चाहिँ अहिले पाइलटिङ गरिरहेको स्टडी गरिरहेको अप्रोच हो यो. र अहिलेको चाहिँ मैले अघि पनि भनिसकेँ यो चाहिँ हाम्रो यो एउटा ब्रोडर टाइप टु हाइब्रिड इम्प्लिमेन्टेसन स्टडी हो. यो चाहिँ स्टेप वाइज क्लस्टर ऱ्यान्डमाइज्ड कन्ट्रोल ट्रायल हो जसले चाहिँ CMHC र NCD को आउटकम हेर्नको लागि डेभलप गरेको डिजाइन गरिएको एउटा बिकम इन्टरभेन्सन प्याकेज छ. त्यसको इफेक्टिभनेस कस्तो हुन्छ त भनेर हेर्ने हो. त्यसको चाहिँ हामी अहिले अर्ली इन्साइट मैले सेयर गर्न लागिरहेको छु. यसमा चाहिँ अलिकति कम्युनिटी लेभलको डेटामा प्रिभ्यालेन्स कस्तो आएको रहेछ र त्यो सँगसँगै हामीले इम्प्लिमेन्टेसन बिकम इन्टरभेन्सन प्रोभाइड गर्दाखेरि चाहिँ आएका फेस गरेका च्यालेन्जेसहरू र त्यसलाई चाहिँ एडप्टेड गरेको स्ट्राटेजीहरू कस्तो छ त भन्ने कुरा चाहिँ यहाँ म सेयर गर्न गएको छु। तर यो भने स्याम्पल र स्याम्पल फ्रेम धेरै गएन, यो चाहिँ दुईवटा पालिकाहरू चन्द्रगिरी र बर्दिवास नगरपालिकाको 29वटा क्लस्टरमध्ये हामीले 20वटा क्लस्टरमा गरेका थियौँ, जुन चाहिँ ऱ्यान्डमली चुज गरेका थियौँ। यो चाहिँ हाम्रो स्याम्पलिङ प्रोसेस र स्याम्पलिङ फ्रेम हो। यो डाटा कलेक्सन प्रोसेसको कुरामा हामीले प्रिभाइलेन्सको लागि चाहिँ रेड क्यापबाट युज गऱ्यौँ र एनालाइसिस चाहिँ हामीले डिस्क्रिप्टिभ एनालाइसिस गरेका थियौँ प्रिभाइलेन्सको लागि भने। अर्ली इन्साइटको लागि चाहिँ यो हामीले एक्टिभिटी लगहरू, इनडेप्थ इन्टरभ्युजहरू, एफजिटीहरूबाट कलेक्ट र फिल्ड भिजिटहरूबाट रेकर्ड गरेका इन्फर्मेसनहरूलाई चाहिँ थिमेटिक रूपमा हामीले अलिकति एनालाइसिस गरेका छौँ। टुलहरूको चाहिँ हामीले चाहिँ डब्ल्युएचओकै टुलहरू, यो हफकिन्स सिम्पटम्स चेकलिस्ट नै युज गरेका थियौँ भने एनसिटी मेजर गर्नको लागि चाहिँ डब्ल्युएचओको जुन पेन प्याकेज छ त्यसले जुन क्राइटेरिया भनेको छ त्यसलाई नै हामीले युज गरेर स्क्रिनिङ गरेका थियौँ। एथिक्स अप्रुभल्स हाम्रो प्रोसेस पनि हामीले कम्प्लिट गरेका थियौँ। क्लिनिकल के अरे यो ट्रायल भएको हुनाले हामीले ट्रायलको पनि रजिस्ट्रेसन गरेका थियौँ। यहाँ चाहिँ म अलिकति यो कम्युनिटी बेसमा चाहिँ अघि हामीले क्लिनिकल बेसको धेरै फाइन्डिङहरू हाम्रो सेयर गरिसक्नु भएको छ मेरो अगाडिका साथीहरूले भन्ने चाहिँ अहिले चाहिँ हामीले कम्युनिटी बेसमा चाहिँ कस्तो रहेछ त सिएमएससी र एनसिडीको चाहिँ कोमोर्बिड भन्ने कुरा चाहिँ यहाँ अलिकति सेयर गर्न चाहेँ। हामीले हाम्रो इन्डिभिजुअल अप्रोच चाहिँ हाम्रो 4619मा चाहिँ 3579जनाको स्क्रिन गर्दाखेरि चाहिँ एन्जाइटीको प्रिभ्यालेन्स हेर्ने हो भने 26% हामीले भेटेका छौँ र डिप्रेसनको चाहिँ 30.12% प्रिभ्यालेन्स थियो, अनि डायबिटिजको चाहिँ 13.94% प्रिभ्यालेन्स थियो भने चाहिँ हाइपरटेन्सनको चाहिँ 64.57% चाहिँ प्रिभ्यालेन्स हामीले देख्यौँ। कोमोर्बिडको कुरा गर्नुपर्दा चाहिँ 28.47% चाहिँ यो कम्युनिटी लेभलको प्रिभ्यालेन्स हो, जो चाहिँ नेसनल इस्टिमेट अघि मैले भने 18% रहेको छ, त्योभन्दा चाहिँ हाई नै छ। त्यो सँगसँगै हामीले चाहिँ बिहेभियर इन्टरभेन्सन हो र यो चाहिँ हाम्रो कम्युनिटी हेल्थ नर्सेसहरूले डेलिभरी कम्युनिटीमा गएर गर्नुभएको थियो। त्यो गर्दाखेरि हामीले चाहिँ केही च्यालेन्जहरू पनि फेस गरेका थियौँ र त्यसलाई चाहिँ स्ट्राटेजीहरू हामीले डिफ्रेन्ट स्ट्राटेजीहरू पनि अप्नाएका थियौँ। यहाँ चाहिँ अलिकति अर्ली इन्साइटको कुरा गरौँ, किन त बिहेभियर इन्टरभेन्सनहरू आवश्यकता छ भनिरहेका छौँ, तर अब हामीले त्यसलाई पाइलोटिङ गर्दा अथवा त्यसलाई प्रोभाइड गर्दाखेरि आउने के आउँदो रहेछ त भन्ने कुरा हेर्दाखेरि चाहिँ यो चाहिँ अलिकति फिजिबल नै छ, उहाँहरूको चाहिँ एक्सेप्टेन्स नै छ। सुरुमा चाहिँ हेर्ने हो भने सुरुमा हेर्दाखेरि चाहिँ अब अलिकति कम्युनिटीबाट ट्रस्ट नभएको, किन नयाँ खालको अलिकति इन्टरभेन्सन भएको हुनाले चाहिँ ट्रस्ट नगरेको, तर पछि ट्रस्ट गरेको सेसनहरूको एक्टिभिटिजहरूलाई उहाँको भनेको छ। डायबिटिज हाइपरटेन्सनको केयरहरू चाहिँ कम्युनिटीबाट चाहिँ रिफरल भएर हेल्थ फेसिलिटीमा आएको भन्ने कुराहरू छ। अनि अलिकति हार्ड टु रिच एरियामा चाहिँ हामीले स्क्रिनिङ गर्न अथवा सर्भिस प्रोभाइड गर्न चाहिँ सिएचडब्ल्यूहरूको चाहिँ काम इम्पोर्टेन्ट रहन्छ भन्ने कुरा रहेको छ। यहाँ चाहिँ अलिकति हाम्रो चाहिँ कम्युनिटीको पर्सपेक्टिभबाट उहाँहरूले चाहिँ आफूलाई यो इन्टरभेन्सनले फाइदा गरेको छ भन्ने कुरा चाहिँ अलिकति यहाँ यो केही भनाइहरू चाहिँ यहाँ राखेका थियौँ। र अलिकति च्यालेन्जहरू के त भन्दाखेरि चाहिँ रिक्रुटमेन्ट र हामीले चाहिँ रिक्रुटमेन्ट गरेपछि डिटेन्सनको च्यालेन्ज हामीले फेस गरेका थियौँ। जस्तो चाहिँ अब इन्टरभेन्सन हो, नयाँ खालको इन्टरभेन्सन देखिँदाखेरि चाहिँ उहाँलाई अलिकति ट्रस्ट इस्युहरू पनि भएको थियो, किन लिने भन्ने खालको, र उहाँलाई चाहिँ त्यो फेरि इन्टरभेन्सन अथवा सेसनहरू प्रोभाइड गर्दा उहाँलाई अन्तिम प्रोभाइड गर्नसम्म चाहिँ लैजानको लागि पनि उहाँलाई अलिकति हामीले च्यालेन्जहरू देख्यौँ। त्यो सँगसँगै सिएचडब्ल्यूहरू जो सिएचएनहरू हुन्छ उहाँहरूको चाहिँ रेगुलर वर्क र हामीले बिकम इन्टरभेन्सनलाई चाहिँ एड गर्दाखेरि चाहिँ अलिकति ब्यालेन्स गर्नलाई थोरै च्यालेन्ज भएको थियो, र त्यसमा फेरि हाम्रो इन्टरभेन्सनको फिडिलिटीको कारणले पनि कतिपय कुराहरू म्यानेज गर्नलाई चाहिँ अलिकति च्यालेन्ज हाम्रो भइरहेको थियो। त्यो सँगसँगै मेन्टल हेल्थ स्टिगमाको कुरा, जस्तो फ्यामिली मेम्बरमा चाहिँ हाम्रो स्क्रिनिङ मेन्टल हेल्थको कुनै कन्डिसन देख्यो भने फ्यामिली मेम्बरले के सोच्छ होला भन्ने खालको एउटा स्टिगमा हामीले भेटेका थियौँ। भने यो इमोसनल फ्याटिगको कुरा गर्दा चाहिँ सिएचएनहरूले डिफ्रेन्ट टाइपको चाहिँ कन्डिसनको केसहरू चाहिँ ह्यान्डलिङ गर्दाखेरि, कम्युनिटीमा ह्यान्डलिङ गर्दाखेरि त्यसले चाहिँ उहाँहरूलाई चाहिँ अलिकति भनौँ कन्फिडेन्ट लेभलमा चाहिँ अलिकति अप्ठ्यारो परेको हामीले भेट्यौँ। त्यो सँगसँगै टेक्निकल हामीले अब सिएचसी टुल थ्रुबाट बिकम एपहरू इन्प्लिट गरेको हुनाले अलिकति टेक्निकल ग्लिचेसहरू पनि हामीले पायौँ। त्यसलाई चाहिँ हामीले थोरै स्ट्रेटेजीहरू अप्नाएका थियौँ। अब स्ट्रेटेजीहरू अप्नायौँ जसमा चाहिँ हामीले अलिकति ओभरफ्लोहरू त्यसलाई एडजस्टमेन्ट गरेका थियौँ। सेसनहरूलाई चाहिँ हाम्रो चाहिँ इन्टरभेन्सन फिडिलिटीलाई चाहिँ असर नगर्ने नि सेसनहरू थोरै एडजस्ट गरेका थियौँ। त्यो सँगसँगै अब जो सेसनहरू हुनुहुन्थ्यो उहाँलाई जसलाई चाहिँ अप्ठ्यारो परिरहेको थियो उहाँहरूलाई चाहिँ हामीले वान वान सेसन हाम्रो क्लिनिकल साइकोलोजिस्टबाट नै प्रोभाइड गरेका थियौँ। अनि ट्रबल सुटिङहरू हुँदाखेरि अब टेक्निकलमा चाहिँ हामीले एनएसएस एनएसएसडीले नै लिड गरेको हुनाले एनएसएसडीको टेक्निकल र हाम्रो टेक्निकल पार्टनरहरूले चाहिँ यसलाई ट्रबल सुटहरू गर्नुभएको थियो र अनि अलिकति टर्नओभरहरू सेसनहरूको टर्नओभरहरूलाई चाहिँ म्यानेज गर्न सेसनहरू प्रोभाइड गर्न डेलिभर गर्नको लागि चाहिँ हामीले स्टडी नर्स भनेर छुट्टै डेभलप गरेको थियो र उहाँलाई सपोर्ट गरेका थियौँ। यो एक्सपेक्टेसन रिकालिब्रेसन चाहिँ हरेक स्टडीहरू गर्दाखेरि चाहिँ कम्युनिटी लेभलबाट डिफ्रेन्ट टाइपको चाहिँ एक्सपेक्टेसनहरू आइरहेको हुन्छ, तर हामीले चाहिँ इम्पोर्टेन्स रूपमा चाहिँ यो तपाईँहरूको लागि नै हो भन्ने किसिमले चाहिँ उहाँको क्यालिब्रेसन गरेका थियौँ भन्ने कुरा यसमा जानकारी गराउन चाहेँ। र यो कन्क्लुजन अथवा टेक अवेमा चाहिँ दुईवटा कुरा हाइलाइट गर्न चाहेँ। अहिले हाम्रो भनौँ न प्रिभ्यालेन्स छ डिप्रेसन, एन्जाइटी र हाइपरटेन्सन डायबिटिजको हाम्रो चाहिँ नेसनल इस्टिमेटभन्दा बढी छ। 18 वर्सेस भन्नु 18 नेसनल छ भने अहिले 28 आयो, यो हाम्रो चाहिँ छ। र यसलाई चाहिँ हामीले कम्युनिटी लेभलमा नै CHW थ्रुबाट डिफ्रेन्ट हामीले केही इन्टरभेन्सनहरू दिन सक्यो भने चाहिँ अब यो फिजिबल पनि छ, इफेक्टिभ पनि छ भन्न चाहेँ। र त्यसको लागि चाहिँ हाम्रो लोकल लेभलको बडीहरू, म्युनिसिपल लेभलको अनि प्राइमेरी हेल्थ केयर सपोर्टहरू चाहिँ एकदमै इम्पोर्टेन्ट रहेको छ। र थ्याङ्क यू भन्न चाहेँ। म टाइममा सिधाएँ मैले चाहिँ। आइड लाइक टु एक्नोलेज टु आवर रिसर्च पार्टिसिपेन्ट्स CW एन्ड अरू हाम्रो कोलाबोरेटिभ पार्टनरलाई चाहिँ एक्नोलेज गर्न चाहन्छु। थ्याङ्क यू।
Thank you. Thank you for ending it in time. I bet there will be questions. तर अब अहिले हामी question नलियौँ because we want to finish this in time. However, there was, तपाईँले higher prevalence देखाउनु भयो, तर तपाईँको this was a very selective group that you were dealing with. So, I mean, how can you compare it with the national prevalence? I mean, there are the questions regarding your study. Nevertheless, I'm sure we'll get to clarify. Without wasting more time, thank you so much. May I now request the next speaker, Mr. Umesh Bilbase, and his paper is entitled Validation of Symptom Questionnaire for Visual Dysfunction, a Psychometric Analysis within Nepalese Population. Hamro Bilbase ji chai, he is a consultant optometrist based in Nepal, and he works at Lumbini Netralaya Butol. He has expertise in binocular vision and specialty in contact lenses, with research interest in visual dysfunction, psychometric validation, and diagnostic technologies. And he has published many papers in peer-reviewed journals as well. So now the floor is yours.
Thank you so much, Honorable Chair, and thank you so much, all the delegates here. So maybe I would like to apologize at first only. The hall is full and everybody wants to listen about the mental health. So I'm kind of breaking that, and I'll be talking about the eye and visual dysfunction. So I hope you will bear me for another 5 to 10 minutes. Well, talking about the visual dysfunction, it's a very broad term, but as the SQVD or the symptom questionnaire for visual dysfunction, we are only talking about the refractive error first of all, and then the binocular vision problem. So visual dysfunction could be because of the mental, the brain injury, or so many problems, so many reasons are there, but we are only dealing with the refractive error and the binocular vision problem. There are a lot of papers and the saying that the visual dysfunction is affecting the quality of life and the productivity for sure. There is a high prevalence of binocular vision. So we have recently completed few studies where something around 4 to 5% is there for the prevalence of binocular vision, and more than 10% are the prevalence of refractive anomalies. And the sad part is that it's growing day by day, and the refractive anomalies definitely it's predicted that predicted by WHO by the end of 2050, almost 50% of the people will be having the myopia. That's kind of scary. But there are still there is no any validated Nepali symptom questionnaire available till date. The objective of this study was to cross-culturally adapt the SQVD in Nepali and to evaluate its psychometric properties and diagnostic accuracy. The study design was a multicentric cross-sectional study that was done between August to December 2025 after getting approval from the NHRC. So we have included 6 eye hospital that was situated in the hilly region as well as the Tarai region. So I would like to tell that we have a limitations that we could not perform this study on the Himalaya region just because their hospital were not really equipped. Wherever they were equipped, the manpower was not there to check the binocular vision problem. There were 305 participants from 18 to 65 years. So what we did was we used the modified Breslin model. For sure, everybody knows about that one. So that was used for the translation. So we have gone through so many steps here, like the cross-cultural adaptation, translation, then we did the expert review and all those things. Then we did the clinical diagnosis, which is binocular vision assessment, and we did RAS analysis, ROC curve, and Spearman correlation. Result, all 14 items, I mean, we had 14 items. The language of the questionnaire was in English, and it was in the Spanish also, but fortunately, unfortunately, we could not go, or we could not align with the Spanish, but we have gone rather through the English language here. Those 14 items showed good fit, that is 0.7 to 1.3. This auto response categories was confirmed. There was no significant gender-based DIF. The minor presbyopia-related DIF was clinically expected. So talking about the reliability and targeting, the Pearson of reliability was 0.81 and the item reliability was 0.84. Unidimensional structural was confirmed with the help of psychometric analysis. There was adequate targeting between the item and the participants. Getting about the diagnostic accuracy, we have used the AUC, and the figure actually confirmed that the chart is going well above the line, and we've got a 0.834, and optimal cutoff score was more than 6, so we've got something around 8 to 9 in some items too. The sensitivity was 0.714, specificity 0.75. The item correlation ranges from 0.326 to 0.613. So the p-value was definitely less than 0.01, indicating the good internal consistency also. These are the Nepali SQVD final instrumentation after the rigorous translation and all those things. So the takeaway message for this study was the Nepali SQVD is a psychometrically robust instrument with good reliability and unidimensionality. That means these questionnaires are only able to justify the visual dysfunction, not the other one. It shows good diagnostic accuracy, that is 0.834 with cutoff more than or equal to 6. It is culturally adapted and validated for the Nepalese population. It provides a practical screening tool for early detection of visual dysfunction. The impact was useful. These are basically useful in the low resource clinical setting. Now, as I've told before, we were not able to use some of the hospital that was available in the Himalaya region. So what we can do to diagnose, or at least to refer the cases, we can use, or the hospital or the department can use this kind of questionnaire, so that if we get any kind of suspicious to or suspicious that it is taking in that direction, we can definitely refer it. So it enables early detection of the visual dysfunction. So what happened, the visual dysfunction, if we could able to find out in the early stages, so the disaster what's going to happen later on can be minimized. So this questionnaires is definitely beneficial to implement. It supports the referral and the triage decisions. It helps optimize eye care resources in Nepal. That was about my short information. I think I'm well within the time. Thank you so much. So we have a time. I think we can answer if we have any kind of questions. So I want to declare at first only, kind of going away from the question, I think I am not a very good statistician. So yeah, the questions are welcome.
Okay. So do you have any question on the floor about this? It's good to save time also because we don't have the time for other speakers. Where is that? Who has? You don't have any. Mental health, so not with this. Okay. Yeah, please.
Sure. The thing is, I cannot conclude that exactly because we have used these tools or the instrument for 18 to 65. So the people in the school would be definitely less than that. So I cannot confirm that we definitely can use that. But for the use of rough idea, maybe we can use. But definitely I cannot conclude that we can use it here.
Okay, because you have already said that you have not a good understanding about statistics, so maybe you won't be able to answer this question. But you see in your slide, you have the area under the curve is about 8 something. So you are saying it's quite highly diagnostic. Accuracy of diagnostic is high, but your sensitivity and specificity is quite low, 0.7 or something. So when both sensitivity and specificity are low, how can you claim that your diagnostic ability is high?
So it's anyway above the line actually.
But you are saying your sensitivity and specificity low. For any diagnostic, it's very low, about 0.73 or something. It has to be above 90% usually for both. So there's something, maybe you can check your data, why it is happening like that, okay? Sure, thank you. Sure. So we go for another, thank you very much.
Thank you so much.
Yes, for the next speaker, Adam, you want to explain? Okay. So now we invite Renasa Khimires, who's speaking on barriers and facilitators to implementing WHO MHCAP suicide protocols in rural primary care settings of Nepal. She is a mental health professional with 9 years of experience in community-based settings. She holds a master's in clinical psychology from University of Delhi. Her research focuses on implementation science, very good, using mixed methods, transdiagnostic treatments, and task-setting approaches with capacity building of non-specialist health worker. The floor is yours.
Thank you. Hi everyone, I'm Renasha and I'm from Possible. On behalf of our team, today I will be presenting on barriers and facilitators to implementing WHO MSCAP suicide protocols in rural primary care settings of Nepal. And I would like to acknowledge all the co-authors and senior authors who have contributed in this work. So this is the outline of my presentation. To set the context, Southeast Asia has the highest global rates at 17.7 per 100,000. And in Nepal, we can see the high rates of suicidal ideation and attempts within the health facilities. However, the disclosure and help-seeking rates are low. While WHO MSCAP 2.0 is implemented in over 90 countries, there is still very limited evidence that if the providers are effectively using the suicide-related practice. So out of these 8 modules, we are focusing on self-harm and suicide modules. And on that regard, we conducted this study to explore provider-level barriers and facilitators to implementing suicide-related practices. And we are also trying to address the existing gaps by using a co-designed suicide prevention package and stronger implementation strategies. So we utilized a framework called RAPIS. It's a combination of ethnography and observation. And our data collection included like in-depth interviews with 14 MSCAP trained primary care providers, 2 focus group discussions with 15 community health workers, and 3-day ethnographic observations at 4 health facilities in these 4 municipalities of Dolakha. Okay, so I'm going to share some of my key findings. So I'll share my findings from my observations. So I want to take a moment to share a specific moment from one of my observations, which I think illustrates the real gap between the training and practice. And in my opinion, I think this one story sums up the entire findings of our overall study. I was observing a 23-year-old MSCAP trained healthcare provider. He was busy sitting in a reception-like area in an open desk with a line of patients waiting. And then a 70-year-old man entered, and the old man looked weak, weary, and like clearly in physical pain. And the old man tells this provider that I'm in pain, my urine is burning, and I need to get my medicine refilled. So the provider, at first the provider strictly treated this case as a physical case. And then he looked at me and said, the man is complaining about physical symptoms. So I don't think there are any mental health issues, right? So, but almost after an afterthought, he's asked a simple probing question to the old man, how is your sleep? And then the whole tone of the conversation changed. The old man shared he hasn't slept or eaten properly in the last 3 months. And then I took the opportunity to ask, "Man kasto cha? How is your heart or mind?" And the old man started to pour out, saying, "I haven't my heart wanders. I'm so much in pain. I find my life worthless, and with all this pain, I wish death had come early." And in less than a minute, what looked like a physical case turned into a serious high-risk mental health situation. But the implementation gap is here. Because the provider did not have a sleep medication in stock, he simply asked the old man to buy it elsewhere and send him off for a urine test. And the old man the whole interaction lasted for 4 minutes, and there was no suicide screening, there was no safety plan, no follow-up, even though a patient had clearly expressed the wish for death. Okay. So I'm going to talk about a little bit of the barriers that we have found. So most of the barriers are revolved around providers' own beliefs and stigmas. So most of the cases, providers share that यहाँ केसहरू नै आउँदैन because the providers felt that the community is not aware, so that's the reason why they don't come. But our observations showed otherwise. It's a missed opportunity. Another barrier is that they wait for a sign. They don't actually proactively ask questions or assess patients, but they wait for a sign to for the patient to self-disclose. It's also because they find the topic suicide very difficult to ask. And providers also describe the word suicide, which is literally translated as atmahatya, as dangerous and feared that asking directly will offend or anger patients. And with this, they providers avoid it, which ultimately and unfortunately keeps the topic stigmatized. Okay, so here is a bit of a use it or lose it situation, because the providers, since they think that the cases don't come, they don't practice it, and since they don't practice it, they lose the confidence to handle a case when when a case actually arrives. So here a provider has clearly mentioned he did not implemented the training because there are no cases. And since he did not, since there were no cases, he could not practice it. And since he could not practice it, he has forgotten it. So it's not just the individual beliefs. There's also some structural constraints within the health facilities that are seen to hinder the ongoing suicide protocol applications. So many health posts lacked private rooms, meaning consultations were happening. It was difficult to create a space for like sensitive conversations. And most of the another barrier is also the training. Most of the trainings led by Nepal government was only came with one-shot training with no follow-up, no technical support afterwards. And mental health has also not been seen as much as a priority for compared to other administrative tasks. So that also shows another barriers. Okay, so it's always not just the barriers. We have also found several things that are already working. Some of the providers were using what I call culturally responsive communication. They were using indirect questioning. They were narrating stories, which were seen effective in helping patients open up. And many health posts had low patient volume, like with just 4 to 10 patients a day, which also gave opportunity for ample amount of time for psychosocial counseling. And some providers had also believed in beyond biomedical models. So support, they believe that supportive conversation can also encourage disclosure. And there were some community level challenges like networks that some providers were already using for follow-up. So with this, we have our larger trial has taken the facilitators as strengths that we can build on, and we have co-designed some solutions to address the barriers that we have just found. So these are the materials from our larger trial, which includes a suicide prevention package, which has structured assessment tool, safety plan as a management protocol, and task shifting follow-up care to CSWs. I hope, since we have just started the implementation of this work, I hope we will be able to share about this in the future. Okay, so in conclusion, we must move from passive care to proactive care, and training alone is not just enough. We need system-level support with ongoing technical support and supervision, and we also need to find a way to make the community aware so that they know where to seek support. Okay, so the key takeaway is opportunities to prevent suicide already exist in primary care. It's the contact point for many people living in rural Nepal. But without structure and support, they are often missed. So I would like to acknowledge all the participants and collaborators. And that's me. You can find me there. And for anyone listening, help is available at 1166 helpline. Thank you.
On time. You want to invite the next one? This one. Gaurav Bhattrai-jiलाई bolau. He's going to talk about national health insurance and healthcare utilization in Nepal, a stratified community-based study of insured and uninsured household. Gaurav ji is an early career public health researcher and public health officer with Government of Nepal. He holds a bachelor's degree in public health from Central Department of Public Health Institute of Medicine. Welcome.
Thank you. Thank you, Chair. And thank you, everybody who are present here for being here and for having this time of day to listen to me. So today I'd like to present our study on health insurance and healthcare utilization in peri-urban Nepal. This is a survey-weighted analysis using Anderson's behavioral model. So to give you a brief background, we also heard yesterday and some speakers today talking about healthcare expenditure and particularly OOP or out-of-pocket expenditure and it being a major problem. So if we look at the raw data, we can find anywhere from about 55% to 60% of healthcare spending coming out of people's pocket. This is a huge problem because this is more than double the global average, and this is the money that people keep to maybe buy assets or even for some families buy food. So sometimes they need to choose food over medicine. So we're talking about people's livelihood and various other grave things at stake here. So OOP is very high and it's a very big problem. To combat this problem, Nepal government launched a national health insurance program. But the problem is it was ruled about 10 years ago, but we lack evidence, information and evidence gap to feedback upon the program and to see its effectiveness. So keeping these things in mind, the objective of this study was to compare the healthcare utilization between insured and uninsured households in peri-urban Nepal using Anderson's behavioral model as a framework. So what we wanted to do was essentially see if the insured households, they used healthcare services more, and we also delineated the types of services that they used in order to see where the gap lied in the program. To give you a brief introduction about the framework which drives this study, it is Anderson's behavioral model, and it's very intuitive. It breaks down all these variables into 3 main domains. The first one is predisposing factors. This pertains to the individual characteristics, such as socio-demographic factors, right? The second one is enabling factors. These are the resources which facilitates or hinders the utilization of services. And the third one is need factors. This is perhaps the most pertinent of all the domains because, for example, chronic illness, it necessitates the use of healthcare services, right? So all these variables, they are like classified into these 3 domains in this Anderson's behavioral model, which is the framework for our study. So methodology, this is a comparative cross-sectional study design. We used a multi-stage stratified sampling technique. So what we did was we got a list of all the insured households from Health Insurance Board, and we contrasted it with the records of the municipal records. So we got the list of insured versus uninsured households. We did multi-stage random sampling techniques, and we ended up with 301 samples, of which 150 were insured and 151 were uninsured. This is a survey-weighted logistic regression with a directed acyclic graph. We'll talk about that later. The setting was in Surya Binayak municipality. So this is a peri-urban setting because it's not too heavily urbanized. There are also some rural touches. And the data was collected through the online platform Kubo Toolbox. It was extracted and analyzed using R. And the primary outcome of this study is the healthcare utilization, but it is again delineated into 5 different types, which are OPD, diagnostic, emergency, inpatient, and preventive services. And the recall period was in the past 6 months. So this was to limit the recall bias, and this was also standard in other papers, so we followed the same. So before moving on to the results, I think it's important to see who enrolls in NHIP. Is it like random enrollment? What is the pattern there, right? So as soon as we see beneath the veneer of all these data, we see many important characteristics of adverse selection, right? So the households who enrolled in NHIP, they were more educated than the households those who were not. They had more chronic illness than those who had not. They had more formal education. So all these data we took from the household heads. So the occupation here pertains to the household head occupation, and the education level also pertains to the same. So as soon as we see this, we see like the enrollment in NHIP is driven by need and as well as by socioeconomic status. So chronic illness, ethnicity, and education. Like we saw in the previous slide, adverse selection is like the consistent throughout these. This graph is again to illustrate the same thing. Sorry. Illustrate the same thing. As we can see here, education, higher secondary level, there was like 16.3 percentage point gap between insured and uninsured households. And I'm not going to go through each one, but you can just see the picture, right? So this again pertains to the same adverse selection problems. Now moving on to the results, what were the results? In the insured household category, among all the insured households, 74% had utilized overall service utilization. So this is any one of these given 5 services, right? And if you look at OPD, diagnostic is like 60, and the diagnostic is 68, and inpatient is 19.3, emergency is 12%, and preventive services is 16.7%. Another interesting pattern here is between insured and uninsured households, almost all the households, they use curative services more, but there was no statistical significant difference in preventive care services. This again is the same similar thing. So between the blue line, it shows insured households, and the red line, it shows uninsured households. You can see the difference between the utilization rates between both of those groups. योभन्दा अगाडि कुरा गरेको चाहिँ एटलिस्ट एकचोटि सर्भिस युटिलाइजेसन गरेको थियो भने यो चाहिँ कतिको चाहिँ द फ्रिक्वेन्सी चाहिँ कति छ त. सो इफ एनी हाउसहोल्ड इनरोल्स इन एनएचआइपी, अब अनइन्स्योर्डले पनि अफकोर्स दे आर गोइङ टु युज सर्भिसेस, इन्स्योर्ड अल्सो दे गोइङ टु युज सर्भिसेस, बट त्यो फ्रिक्वेन्सी अफ युटिलाइजेसनमा चाहिँ स्ट्याटिस्टिकल सिग्निफिकेन्टली डिफ्रेन्ट छ कि छैन भनेर हेर्दाखेरि मोस्ट अफ द सर्भिस टाइपमा थिएन, एक्सेप्ट फर वान विच इज ओपिडी सर्भिसेस, जहाँ चाहिँ इन्स्योर्ड हाउसहोल्ड्स दे युज लाइक 2.93 यो times versus like your average ma garदाखेरि over the past 6 months भनेपछि uninsured को चाहिँ 2.34 थियो, and this was statistically significant. Now this is the adjusted logistic regression survey. We did adjusted logistic regression results, and as soon as you see here, you can see a few patterns. है तलबाट सुरु गर्नु पर्दाखेरि NHIP enrollment यो सबै मोडल्सहरुमा रन गर्दाखेरि सबै यो ओपीडी सर्भिसेस, ओभरअल युटिलाइजेसन र डायग्नोस्टिक सर्भिसेसमा चाहिँ इट वाज लाइक स्ट्याटिस्टिकली सिग्निफिकेन्ट प्रिडिक्टर एक्सेप्ट फर प्रिभेन्टिभ सर्भिसेस. सो इन्स्योर्ड हाउसहोल्ड्सहरू प्रिभेन्टिभ सर्भिसेसहरूमा चाहिँ त्यो खासै त्यो फरक देखिरहेको थिएन क्या वेन कम्पेयर टु अनइन्स्योर्ड हाउसहोल्ड्स, राइट. यु क्यान अल्सो सी लाइक क्रोनिक इलनेस. इट्स भेरी इन्ट्रेस्टिङ. द हाउसहोल्ड्स विथ क्रोनिक इलनेस उनीहरूले चाहिँ प्रिभेन्टिभ सर्भिसेस अझै कम युज गरिरहनु भएको थियो क्या. अनि द सेम विथ द सेक्स अफ द हाउसहोल्ड हेड. So male-headed household heads, they utilized preventive services less than female-headed household heads, which is another interesting pattern, right? So I think this is a very information-dense graph. Yeah, moving on. So, अब यसलाई रिजल्ट्सलाई अलिकति ब्रिफली भन्नु पर्दाखेरि ओभरअल युटिलाइजेसन वाज भेरी हाई. सो इन्स्योर्ड हाउसहोल्ड्सहरूले चाहिँ अलमोस्ट 2.6 अथवा 2.7 टाइम्स द अर्ड्स अफ युटिलाइजिङ द हेल्थ केयर, ओभरअल हेल्थ केयर मोर, जहाँ चाहिँ क्युरेटिभ सर्भिसेसहरू चाहिँ उहाँहरूले अझै बढी युज गरिरहनु भएको थियो क्या. सो एनएचआइपी इनरोलमेन्ट ह्याड एडजस्टेड अड्स रेसियो अफ 2.7, तर इट वाज नट द सिङ्गल बिगेस्ट प्रिडिक्टर. द सिङ्गल बिगेस्ट प्रिडिक्टर वाज अगेन क्रोनिक इलनेस. सो मोस्ट अफ द हेल्थ केयर युटिलाइजेसन इट इज ड्रिभन बाई क्रोनिक इलनेस. देन कम्स सोसियो इकोनोमिक स्टेटस, एन्ड देन ओन्ली कम्स इन्सुरेन्स इनरोलमेन्ट स्टेटस. सो द की टेकअवेज, वाट आर द की टेकअवेज भन्दाखेरि insurance works, right? Insurance works. Insured household go and they do use healthcare services. And again, healthcare services use गर्नेमै हेर्दाखेरि पनि most of the households they did not show the patterns of moral hazard. किन भन्दाखेरि त्यो there was no statistical significance in the frequency of service use, right? अनि the preventive care gap was there. I think this represents a big missed opportunity from the programmatic section. एनएचआइपी को अब गएर सर्भिस प्याकेजमा हेर्दाखेरि पनि प्रिभेन्टिभ सर्भिसेस चाहिँ मेन्सन छ, तर इट डज नट डिलिनिएट कस्तो के हो भनेर. र हाम्रो अलरेडी रनिङ जुन फ्री प्रिभेन्टिभ केयर सर्भिसेसहरू पनि छन्, जस्तै नेसनल इम्युनाइजेसन प्रोग्राम भयो होइन, अथवा फुड सप्लिमेन्टेसन प्रोग्राम भयो, र न्युट्रिसन प्रोग्राम्सहरू भयो. वी क्यान सी मेनी ओभरल्याप्स बिट्विन दिज. सो यो के हो त प्रिभेन्टिभमा के पर्छ भनेर पनि खासै छैन, र हाउसहोल्ड्सहरूले पनि त्यो प्रिभेन्टिभ केयर युज गरेको हामी खासै देख्दैनौँ. The socio-economic barriers was also there. So ISES households, socio-economic households with high status, they were 3.4 times more likely to use the services, right? So we can see the adverse selection problem throughout this. So health insurance ko duita primary कुरा भनेकै risk pooling र risk sharing हुन्छ. अब त्यो risk pool मा सबै त्यो at risk मात्र household आउनु भयो भने त्यो प्रोग्राम त कहिले पनि financially viable हुँदैन नि. अनि अहिले पनि we can hear अब न्युज आउटलेट्सहरूमा पनि टर्शियरी केयर सेन्टर्सहरू दे आर रिफ्युजिङ एनएचआइपी आउटराइट, राइट. अब भोलिको दिनमा त अब मै पनि छु भने आई विल बी हेजिटेन्ट टु गो एन्ड इनरोल इन द एनएचआइपी बिकज अफ अल दिस, राइट. So yeah, this was the end of my presentation. I'd like to thank everybody who played their part in making this study happen. I'd like to thank my co-authors and my college. This is my bachelor's thesis. This is me, and thank you very much. Yeah.
Thank you, Mr. Gaurav. Very good presentation, and we don't have time as usual, so sorry for for interaction. But what is your central message then? I'll give you 1 minute. What do you want to say?
My central message is health insurance works. We can see that in the data. But who does it work for? हामीले कसलाई टार्गेट गरेको छौँ त? हामीले यहाँ हेर्दाखेरि जो चाहिँ एकदम धेरै बिरामी हुनुहुन्छ उहाँले युज गर्नु भएको छ, ठिक छ, तर विथ दोज विथ हायर सोसियो इकोनोमिक स्टेटस, दोज विथ फर्मल अक्युपेसन, दोज विथ अरू यो हुन्छ नि त्यो सोसियो इकोनोमिक स्टेटस हाई भएको क्लासको लागि चाहिँ अझै धेरै काम गरिरहेछ क्या. सो देयर इज लाइक पिपल एन्ड देयर इज लाइक फ्यामिलीज एन्ड देयर इज हाउस होल्ड्स वर गेटिङ लेफ्ट बिहाइन्ड हुन्छ नि. त्यो प्रोग्रामको त्यो स्लेटबाट स्लिप गराउनु भएको छ क्या उहाँहरू. सो एनएचआइपी काम गरिरहेछ, तर यसलाई अझै बेटर डिजाइन गर्न सक्ने हो कि अझ अरू सर्भिस टाइप्सहरू पनि केलाएर हेर्दाखेरि चाहिँ प्रिभेन्टिभ सर्भिस त्यस्तो युजै गराउनु भएको छैन. कसरी चाहिँ एनएचआइपीले यसलाई एड्रेस गर्न सक्छ त भन्ने कुरा. अनि अर्को एउटा क्याभिएट पनि छ, दिस अ भेरी स्मल स्केल स्टडी है. अब यो स्टडी गर्दाखेरि सो मच पोटेन्सियल देखियो, तर दिस जस्ट 301
Thank you very much. We got your point. Thank you. So now we invite, you can go. So now we invite Babita Ghimire, who is a nursing student. She is actually assistant professor, vice principal, and head of the Department of Nursing at Sri College of Technology. She holds a master's degree in nursing from Chitwan Medical College, Tribhuvan University, and she will speak about nursing students' knowledge and their attitude. Okay, thank you. Floor is yours.
Good afternoon, respected chairs, dear all. It's me, Babita Ghimire, talking about patient safety, nursing student knowledge, and their attitude. Before going to the presentation, I want to thank NHRC for providing this platform, because this topic is less discussed and more faced during the care of the patient. While talking about the patient safety, it's about the making the healthcare safer for the everyone, not only for the patients, that for the families, healthcare workers. So it focuses on the creating the systems where mistakes are less likely to happen. You can see here the flow chart of patient safety. It addresses the 4 components, where culture, where safety first the mindset, proper communication is required, and the second one is the processes, where clear steps and guideline is required, and the third one is the technology, safe tools and system is required for the patient safety, and then last is the environment, clean, organized healthcare setting is required. So for this, it will reduce the risks and reduce the harm. Then fewer errors will occur, safer care will be there, and better outcomes of the patient care. Patient safety is the fundamental provision in all healthcare settings. So avoidable adverse events, errors, and risks associated with the healthcare remain the major challenges globally. You can see this the wheel here, where patient's safe future will be addressed. So for the development of the policies, strategies, action plan, and programs for the patient safety is still in its early stages. Now, for the patient safety issues, annually there are 134 million healthcare associated adverse events, contributing to 26 million deaths in the hospitals. In developing countries like Nepal, overcrowding, shortage of equipments, and the supplies, shortage of staffs, poor hygiene and sanitation, disinterested leadership, and the flow process of care have contributed to the unsafe patient care. So nurses, as we know, nurses are the largest group of the healthcare providers, are the best position while providing the patient safety. So preparing the nurses educators have the important role in developing the knowledge, skill, attitude among the nursing students related to patient safety. Lack of the patient safety can pose serious health risks like the worsening of the patient condition, deterioration in patient health, and infection and complication will arise in the patient condition. So this study is more concerned regarding the assist patient safety, nursing student knowledge, and their attitude. The objective of the study is to assist the patient safety, nursing student knowledge, and their attitude. Specific objective to find out the patient safety, nursing students' level of knowledge and their attitude, and to identify the association between patient safety, nursing student level of knowledge, their attitude, and selected variables. Talking about the methodology, quantitative study, a cross-sectional analytical study design was used. setting was nursing colleges, where undergraduate nursing students were selected to assess whether they were aware about patient safety or not. As already I mentioned, undergraduate nursing student of the college in Bharatpur Chittagong was the study population. Talking about the sampling technique, 2 nursing colleges which are affiliated to Purvanchal University in Chittagong, probability simple random technique was used, lottery method was applied, and select the college for the data collection among undergraduate nursing students. The sample size is 131 undergraduate nursing students. The research instrument is semi-structured self-administered questionnaire, which consists of socio-demographic information, knowledge-related questionnaire, and for the attitude Likert scale is used. For the validity, expert consultation were done with the subject experts, and the extensive literature review was done. Pre-testing was done in the 10% of the total population, and reliability score is 0.7 regarding the knowledge and the 0.65 regarding the attitude toward the patient safety among nursing students. Ethical consideration, IRC approval was taken, written informed consent was obtained, and respondent was explained about the objective of the study in the clear and understandable term. Confidentiality was maintained, and the respondent were aware about the withdraw their participation at any time during their data collection, and anonymity was also maintained by using the code number instead of name. Semi-structured self-administered questionnaire was used for the data collection, asking and taking the time for the from the year coordinator before the data collection, and data was collected during the free time of the students, and students are given 20 to 25 minutes to complete the questionnaire. So after the completion of questionnaire, check for the completeness, then after it was collected. So researcher made every possible attempt to reduce the bias in the data collection. Data was collected in 2024 to 18 to 31, and after the collection of data, checked, review, and organized for the accuracy, completeness, and consistency, coded and entered in the Access, and then analyzed by the SPSS. For the descriptive, in terms of frequency, percent, mean, and standard deviation, and using the inferential statistics, PR chi-square likelihood ratio in 95% of the confidence interval. Now the result of the study, there is 85.5% of the respondent belongs to 15 to 25 years age, and 45.8% belongs to BSN first year, and 93.1% have less than 1 year experience in the clinical practice. Regarding the level of knowledge, only the 51.9% respondent have good level of knowledge, and 51.9% respondent have poor level of attitude regarding patient safety. So there is significant association between the knowledge regarding patient safety and age, level of education, and experience of clinical practice of the nursing students. And there is significant association between attitude regarding patient safety and the age of the nursing students. Now, the conclusion of this study, about half of the respondents had poor knowledge regarding the patient safety, more than half of the respondents had negative attitude. Age and experience of the clinical practice is significantly associated with the knowledge regarding patient safety, where the age is the significant associated with attitude regarding the patient safety. So there is a still need to do more focus on the concept, skills on patient safety among the nursing students. If nurses have high patient safety skills, then that will improve the patient satisfaction. Lastly, takeaway message is, the time to act is now to ensure the safer healthcare environment for the everyone. Urgent call to action, bridging the patient safety gap in the nursing education. There is a knowledge deficit, attitude problem, and the solution, more than half of the respondents held a negative attitude toward the patient safety protocols. The solution, we must intensify our focus on integrating the practical patient safety concepts and skill into the nursing curriculum. So ultimate goal will be the equipping nurses with the high level of safety skills is a direct path to significantly improving patient safety satisfaction and care quality. Lastly, I want to acknowledge nursing students for their valuable time and information. These are the references, and then it's me. And thank you so much.
Thank you very much. We still have about 1 minute. I think she raised a very serious, issue here. Like, okay, so please, your front. Okay, you start from there.
मेरो जिज्ञासा अलिकति यो हाम्रो क्वालिटी जुन एजुकेसनको छ त्यसमा नि एउटा क्वेसन जस्तो यहाँ देखियो हैन त्यहाँ हामीले कतिको चाहिँ स्टुडेन्टहरुलाई त्यो नलेज डेलिभर गर्न सक्यो अथवा उहाँहरु लिन सक्यो भन्ने कुरा मेरो जिज्ञासा यो पूर्वाञ्चल युनिभर्सिटीको कलेज मात्रै किन कि प्रेजेन्टेसनमा त्यो आएको थियो हैन त्यसको रेपुटेसनको कुरा हुन सक्छ त्यसको कुराहरु लाइक यसमा ध्यान राख्यो कि राखेन भन्ने कुरा
Okay, we'll take another question also and then she will respond. Yeah.
Thank you for your nice presentation. मलाई चाहिँ एउटा क्वेसन चाहिँ जस्तो 50% हाफ अफ नर्सिङ स्टुडेन्टहरुमा चाहिँ एटिट्युड पनि कम छ नलेज पनि कम छ हैन एज एन नर्सिङ इन्स्ट्रक्टर व्हाट हैव यु डन टु इम्प्रुभ देयर नलेज भन्न चाहन्छु अनि अर्को कुरा चाहिँ करिकुलममा इन्डोर्स गर्नुपर्छ भन्ने जुन रिकमेन्डेसन आयो हामीले दुईटा कलेजको डेटाको बेसिसमा करिकुलममा इन्डोर्स गर्नुपर्छ भनेर कसरी भन्न सकिन्छ भन्ने मेरो एउटा क्वेसन थ्यांक यू
त्यसमा म पनि थप्छु त्यो एटिट्युड कम छ मात्रै हैन नेगेटिभ एटिट्युड छ भन्नुभएको छ तपाईले हैन मोर देन 50% दैट्स अ सिरियस प्रब्लम के छ यसको अलिकति भन्नु
पर्सनल्ली म एकाडेमिक इन्स्टिट्युसनमा भएको कारणले गर्दा पनि मैले यो फिल गरेको टपिक हो जसमा चाहिँ मैले हस्पिटलमा पनि बेड साइड केयरहरुमा पनि सुपरभिजन गरिरहेको हुन्छु एज वेल एज एकाडेमिक इन्स्ट्रक्टर पनि हुँ मैले फेस गरेको एज अ टर्नओभर धेरै भएको कारणले गर्दा मोर एक्सपिरियन्स नभएको कारणले गर्दा अनि थ्योरी त कुराहरुको पार्टहरु करिकुलममा एड्रेस त गरिन्छ बट द एटिट्युडको हिसाबले चाहिँ हाउ अझै स्टिल हामीले पनि त्यसलाई चाहिँ मोर एड्रेस गर्न सकिरहेको छैनौँ जो कारणले गर्दाखेरि चाहिँ जस्तो पेसेन्ट भन्ने बित्तिकै पेसेन्ट हो भन्ने खालको हिसाबले चाहिँ स्टाफ र नर्सिङ स्टुडेन्टले हेरिराख्नु भएको हुन्छ दे आर फ्रम द हायर अथोरिटीबाट पनि आउनुभएको हुनसक्छ अथवा लोवर लेभलबाट पनि वर्कर्सहरू आएर पनि पेसेन्टको हेल्थ केयर सर्भिसहरू लिइराख्नु भएको हुन्छ तर स्टाफ्सहरूको बिलिभ कस्तो देखिरहेको हुन्छु भने मैले उहाँहरू त पेसेन्ट हो यति नम्बरको पेसेन्ट यो पेसेन्ट यसरी केयर गरिराख्नु भएको हुन्छ जसले गर्दाखेरि चाहिँ हामी आफै नै बेडमा बस्दाखेरि चाहिँ पेसेन्ट सेफ्टी लिनको लागि चाहिँ उनीहरूलाई चाहिँ एटिट्युड नै चेन्ज गर्नुपर्छ जसले गर्दा ओहो बिरामीलाई त गाह्रो पो भएको छ बिरामीहरूलाई चाहिँ हामीले चाहिँ सिरियसली हेर्नुपर्छ हैन तिनीहरूको हेल्थ कन्सर्नमा मोर एड्रेस गर्नुपर्छ भन्ने कुराको पार्टमा अझै स्टिल अवेर नभएको कारणले गर्दा नै मैले यो टपिक लिएको किन भन्दा यो यस्तो देखियो हजुरको पार्टबाट गर्नुभयो भन्दा मैले यो चाहिँ ओरिजिनल रिसर्च भएको कारणले गर्दा अहिले स्मल स्केलमा गरेको भए तापनि मैले चाहिँ यो चाहिँ लार्ज स्केलमा गर्नुपर्ने चाहिँ प्लान पनि राखेको छु र यसमा चाहिँ यो रिजल्टलाई हेरेर हामीले नर्सिङ एसोसिएसन अफ नेपालमा पनि जुन कमिटीमा डिस्कसन गर्दाखेरि चाहिँ पेसेन्ट सेफ्टीलाई चाहिँ मोर एड्रेस गर्नुपर्छ है भन्ने रियलाइजेसनमा डिस्कसन पनि भएको थियो र त्यो हिसाबले हामीले प्रपोजल मिनिस्ट्रीमा पनि प्रपोजल पठाएर अनि त्यसको इन्टरभेन्सन प्लानमा पनि छौँ जसले गर्दा चाहिँ डिफ्रेन्ट प्रोभिन्समा अल प्रोभिन्समा चाहिँ हामीले पेसेन्ट सेफ्टी रिलेटेड इन्टरभेन्सन पनि गर्न लागिरहेको छौँ त्यो चाहिँ मैले रियलाइजेसन आफैले गरेको कारणले गर्दाखेरि पनि यो कुराहरुमा मोर एड्रेस
Thank you very much.
Thank you all.
Okay, very brief, please. Yeah.
Thank you very much. मेरो स्वर पनि भ्याउँछ होला त्यसकारणले गर्दाखेरि जस्तै उहाँले अघि भन्नुभयो म नर्सिङ एसोसिएसन अफ नेपालको प्रेसिडेन्टको हैसियतले पनि हामीले अहिले पेसेन्ट सेफ्टी रेस्पेक्टफुल पेसेन्ट केयरलाई फोकस गरेर क्यापासिटी बिल्डअप गर्ने भन्ने प्लान चाहिँ गरिरहेको छौँ हामीले हैन त्यसकारणले गर्दा उहाँले सर्ट ग्लान्स स्टडी गर्नुभयो होला हुन त उहाँले एन्सर गर्नुपर्ने हो अब सर्ट टाइम भएको भएले पर्पसिभली उहाँको कुरा चाहिँ एकदम जेन्युन हो अगाडि सरले सोध्नु भएको थियो वाइ ओन्ली पूर्वाञ्चल युनिभर्सिटी भन्ने कुरा हैन त्यसकारणले गर्दा अलिकति त्यसलाई थोरै एट अ ग्लान्स हामी केही लिनु सक्छौँ कि भन्ने किसिमले अहिले तत्कारो धेरै प्रब्लमहरू आइरहेछ क्या कम्युनिकेसन राम्रो गरेन राम्रो फेस गरिरहेको छैन अस्ति भर्खरै पनि एउटा उजुरी कहीँ कतैबाट आएको छ आई हेभ टु मेन्टेन द कन्फिडेन्सियालिटी होइन के अरे राम्रो बिहेभ गरेन पेसेन्टलाई भनेर चाहिँ कहीँ कतैबाट नर्सिङ एसोसिएसनमा उजुरी आइरहेछ हेल्थ वर्कर भनेको छ एन्ड वी ट्राई टु फाइन्ड आउट द्याट वाज दि प्यारामेडिक्स होइन अब एनिवे म त्यो कन्फिडेन्सियालिटी मेन्टेन गर्छु यहाँ त्यस कारणले गर्दाखेरि यो नर्सिङ अहिले कम्पिटेन्सी बेस्ड एजुकेसनमा फोकस गरिरहेछ मेडिकल एजुकेसन कमिसनले कम्पिटेन्सी डेभलप गरेर एटिट्युड नलेज स्किल अब जस्तै त्यो कारणले गर्दाखेरि नै हामीले मेन्टल एबिलिटीको कुराहरू पनि यो कमन इन्ट्रेन्स एक्जामिनेसनमा राखेर लैजानुपर्छ भन्ने कुरा पनि फोकस गरिएको हो त्यस कारणले गर्दा उहाँले अब नर्सिङ फ्रेटर्निटीमै रहिरहँदाखेरि पनि यस्ता खालका प्रब्लम एकदम धेरै आइरहेछ किन आयो भन्ने पछाडि पनि हामीले स्टडी गर्नुपर्छ भन्ने लाग्छ मलाई है किन वाइ दे आर नेगेटिभ वाइ एटिट्युड नेगेटिभ भयो भन्ने पछाडि पनि देयर मस्ट बी सम रिजन सो त्यो पनि हामीले फाइन्ड आउट गर्नुपर्छ जस्तो लाग्छ थ्याङ्क यू भेरी मच थ्याङ्क यू
Thank you. Yes. I would now like to request the last speaker, Sabina Dongol. Is the head of laboratories at OUCRU Nepal and a medical microbiologist with a doctorate in philosophy from University of Oxford. Her work focuses on enteric fever, antimicrobial resistance, improving diagnostic strategies in resource-limited setting alongside strengthening lab capacity and supporting clinical research. Very impressive.
Thank you for the nice introduction. I'm Sabina and I'm from Okra, Nepal. So I'll be talking about enteric fever and the diagnostic challenges that we face. So for the diagnosis of enteric fever, first of all, enteric fever is caused by Salmonella typhi and Salmonella paratyphi A, B, and C. We see a lot of Salmonella typhi and paratyphi A, but we don't see that much of B and C. For the diagnosis of enteric fever comes under the undifferentiated febrile illnesses. So there is the signs and symptoms that overlaps with a lot of other diseases like dengue and malaria. So for the diagnosis in our setting, mostly it's the blood culture. But blood culture is the gold standard. However, its sensitivity is very low and it depends on various parameters. For example, the volume of blood, timing of blood culture, and the prior antibiotics taken by the patients. And it is not cheap, it is quite expensive, and the turnaround time is slow. It normally takes at least 3 days for the culture and sensitivity results. So this delays the treatment, and also we need a lab facility that is required as well as the trained personnel. So as a result, the serological tests are quite common, and in our setting we see that it's mostly Widal or other RDTs, for example like Tubex, Enteroscreen. These RDTs are very commonly used. However, Tubex, just to inform you, is not available in Nepal, but we have other RDTs that I will be showing you in the results section. These have serious limitations because they can be cross-reactive, maybe negative early in infection, and most importantly, these have never been validated on our samples. So we don't know what is the sensitivity and specificity of those RDTs. So what is the current practice of enteric fever diagnosis? So diagnosis and treatment are primarily guided by clinical judgment. Patients with fever lasting for more than 3 days and suggestive symptoms are often started on empirical oral antimicrobials. Some RDT tests are performed. Widal is most preferred, although this is a very old, probably 100 years old test, and it is not sensitive and specific, especially in our setting, but still it's most preferred. And blood culture is performed in some cases, but this is not a routine practice. And there are some publications which show that PCR tests are very good, and there are some papers that indicate that this is not so good. So again, this is expensive and not a common practice. So in this study, I have like a few study components. First, we collected the retrospective microbiology data from 10 different hospitals from Kathmandu. The objective was to see what the prevalence of Salmonella typhi and paratyphi from blood culture isolates, and also to look at the serological test if these are conducted in the hospitals. The timeline was January 2020 to December 2024. Next, the purpose of collecting those data is to identify the three most commonly used RDTs across those hospitals, and then validate these tests on plasma samples collected from participants from recently completed ACT South Asia typhoid trial. And because typhoid is treated based on the clinical signs and symptoms, we also wanted to explore whether we could develop a clinical score. And last but not the least, we wanted to see if the PCR works on our samples. So this is the data from 7 hospitals that I have so far, and you can see that from at the same time period, the 5 years time period between 2020 to 2024, you can see that various blood culture results. I mean, the blood cultures were mostly more commonly done in the pediatric hospitals than in other hospitals. And talking about the salmonella isolation was very low, from 2.3% to 0.4%. So the blood culture is done. The blood culture numbers are high because we don't have information whether these were done from the suspected enteric fever patient or other infections. So we do not have that information. And from the RDT test, we could find out that Widal is most preferred one, and other tests that were commonly done across the hospitals were acro and enteroscreen. So we validated those 3 tests on our ACT samples. We validated them on a total of 426 samples. Out of these, there were 58 that were culture positive, and remaining were culture negative. We can see from the results that the sensitivity is below 50%, and even with Widal, the performance of Widal is very, very poor. Specificity you can see a bit high because the sensitivity is very poor, and there is not any test that we could recommend. Before initiating the study, we thought that we will try to identify one RDT that probably we could recommend to be used across all the hospitals. But from these results, there weren't any tests that perform better because the sensitivity were very low. So next, we try to look at the developing a clinical score. For this, we collected 5 clinical data sets from Bangladesh, Cambodia, and Nepal. The combined data sets were equally divided into derivation and validation cohort. From validation cohort, logistic regression was performed, and 5 clinical variables were identified that were associated with blood culture conformed patients. And from there, the clinical score was derived and based on the beta coefficient, and this was then used on the validation data sets. And we also added RDT to see if it increases the positive predictive value. So this is the logistic regression from where we could identify that headache, abdominal pain, diarrhea, absence of cough, and temperature more than 39 degrees centigrade were positively correlated with the typhoid patient who were culture positive. And based on the beta coefficient value, the point value was given. For headache, it was 2, and for all other symptoms, it was 1. So a total score of 6 was given. So how it performed, we try to use this scoring system. If the point is below 5, then it could detect 22 culture positive, so that get the 7.5% culture positive. And if the point was more than or equal to 5 points, then 82 of the culture positive patients could be identified. So we also wanted to see if it increases the positive predictive value if it is added along with the RDT test. Here we use the tested typhoid, which is not commonly used in Nepal, but But the papers have suggested that this has a better sensitivity and specificity. If you look at this result, the positive predictive value has increased from 36.2% to 52% when it was used along with the clinical score that is more than or equal to 5. So next, we looked at the real-time PCR because PCR is said to be a very good test for everything, but for typhoid, it is not as not good as we expected it to be. We used 2 sets of primers for Salmonella typhi as well as for Salmonella paratyphi A separately. You can see from the results that we tested this on 300 samples. Out of these, 72 were blood culture positive. PCR was positive only on the 18 samples. Among these, 11 cases were also positive by blood culture method, but it could not pick up the 62 blood culture positive ones. However, it picked up 7 culture negative ones, so that gave the sensitivity of 15.2%. So in summary, Widal test is widely used, but its performance is very, very poor. Locally available RDTs also had the poor diagnostic accuracies, and it was difficult to read the results as well. So we are also exploring hemolysin E antigen, which is a newly detected antigen for the detection of Salmonella typhi and paratyphi, and which is said to be a better serodiagnostic marker. Our results with PCR showed poor sensitivity. And finally, we derived a simple clinical score, which could be used to enhance the positive predictive value of typhoid RDT. And one of the major limitations of this study was that everything was compared with blood culture, which is said to be imperfect sensitivity. So this made the evaluation of new diagnostics for the disease very challenging. So with this, I'd like to thank the funders and my mentors and supervisors who made this work possible. And with this little bio, I'd like to conclude my presentation.
Thank you. Thank you very much. I think you are the last speaker of today's session. People are waiting for the lunch, I think. And but because I also see that Professor Buddha Basnet is here, kind of, who must have supervised this.
Yes.
And this is also sensitivity and specificity, a lot you have discussed. So my question is, what you are taking a one-step test or you are doing 2 steps, you know? For example, Widal has 100% specificity, right? But we are saying it's a poor test. Why? I mean, if it has 100% specificity, as if you have done a large sensitivity, then excluded the false positives by highly specific test, then it would have been very useful Widal test, right? Yeah, so in your problem is that your sensitivity is very low. So that's why you're designing a clinical score to increase the sensitivity. But even that sensitivity is not increasing your specificity to the extent that you want, you know. So why don't you combine both, clinical score and Widal test, or PCR? PCR also has very high specificity.
Yeah, we could explore into this. I mean, this is an ongoing work, and we would definitely like to see if combining those score with Widal and combining those score with Interoscreen and other tests as well. At the moment, we just did with the tested typhoid RDT.
Yeah, but the thing is, what we want is actual diagnosis of patients, no?
Yes.
So why do we push for only one test? Why it can't be like 2-step test, you know? You do a very sensitive test, which has more than 90%, and then the false positive you can remove by 2nd step, you know, like Widal or PCR or whatever. Yeah, so, but if you push only one, then you are making a mistake of having 67% and 70% of a specificity, and that will also not give, I mean, many people will be lost. Yeah. Diagnosis.
Why we tested just one RDT is that the literatures have said that this is a better performing RDT. But as you said, we could explore this with. We don't have the RDT that is that has a good just the average sensitivity, but not a good.
Thank you very much. So maybe we go for. It's already very late. So what the mass says, you know, if you still go for one question, yeah, you want? Okay. Introduce yourself.
Yeah. I'm Dr. Pramod Shangwa. I'm a psychiatrist, and my experience, yeah, nearly 3 decades in mental health. So it is not related to you. Just I want to say some my observations and some comments because there are many mental health related papers presented here. So just I attended yesterday. PAN means Psychiatric Association, Nepal Psychiatric Association, and I found that there are 285 psychiatrists. And when I did my psychiatry in 1998, there were just 25 psychiatrists. So there is a very good, expansion of the number of psychiatrists. So I think a curative part will be well covered in coming days. And another very striking point is the suicide rate. Suicide rate is very, very high for Nepal. If you look at the global trend, it is around 9 or 10 per 1 lakh population. And the global trend is now decreasing. It is going, last 30 years, it is decreasing. So it is very alarming sign for all of us, and probably we should set the target, how to decrease the number of suicide incidents. And that is only the tip of iceberg, There are under reports.
Please be brief.
Okay, and the next is the anxiety and depression. It was very high, 26 or something like that. If you look at the Indian household data, it says around 3% of depression and 4% anxiety disorder. So why that is so high for Nepal? And thank you, sir. I am going to attend the brain and mind seminar. Thank you.
हेलो सर नमस्ते म डक्टर राम थापा छेत्री हेल्थ इन्सुरेन्स बोर्डबाट रिप्रेजेन्ट गर्छु र मेरो चाहिँ हाम्रो हेल्थ इन्सुरेन्सको कुरा पनि आयो यो नेपालको हेल्थ इन्सुरेन्स सिस्टमलाई बलियो बनाउनको लागि चाहिँ सबभन्दा पहिला यो सेवा प्रदायक संस्थाहरू आफू इमान्दार हुनु पऱ्यो। म आफू पनि क्लेम म्यानेजमेन्ट गर्छु, त्यहाँ एउटा कुनै प्याकेज उनीहरूले क्लेम गरेछ भने 200 रुपियाँ 1000 रुपियाँ 5000 रुपियाँ एक्स्ट्रा हाल्ने, त्यो पछि राज्यलाई क्षति भयो नि त। हामीसँग 750वटा पालिका लेभलका करिब 300 भन्दा बढी सेवा प्रदायक संस्था छन् र उनीहरूले चाहिँ यसरी चाहिँ थोरै मात्रामा पनि एक्स्ट्रा क्लेम गर्यो, फ्रड क्लेम गर्दाखेरि राज्यलाई धेरै क्षति पुगेको अवस्था छ। र हाम्रो कोष बलियो बनाउनको लागि चाहिँ सबै निजामती कर्मचारीहरू, नेपाली सेना, नेपाल प्रहरी, सशस्त्र प्रहरी बलको सबै औपचारिक क्षेत्रका चाहिँ कर्मचारीहरूले त्यहाँ 5000 रुपियाँ अथवा निश्चित एमाउन्ट चाहिँ हामीले त्यहाँ कन्ट्रिब्युसन गर्ने हो भने त्यो कोष आफै बलियो हुन्छ। र अर्को कुरा, र नेपाल गभर्मेन्टको हेल्थ मिनिस्ट्रीको सबै प्रोग्रामहरू हेल्थ इन्सुरेन्स बोर्डमा ल्याउने हो भने त्यो पनि एउटा सहजताको रूपमा हुन्छ भन्ने लाग्छ मलाई। र सबै स्वास्थ्य संस्थाहरूले चाहिँ पारदर्शी तरिकाले चाहिँ आफ्नो क्लेमहरू पठाउँदाखेरि चाहिँ हामीले चाहिँ काट्नु नपरोस्। उनीहरूले हामीले धेरै काट्यो भन्छन्, तर धेरै काट्ने भन्दा पनि फ्रड क्लेम चाहिँ हामीलाई रिइम्बर्समेन्ट गरा भएर हामीले काट्नुपर्ने अवस्था छ। र मेन्टल हेल्थको इस्युमा हामीले 2 दिन अगाडि पाटनको एउटा घटना देख्यौँ। त्यहाँ एक शब्द चाहिँ मिस कल जाँदाखेरि 2 जना युवाको हत्या भएको अवस्था छ। त्यही दिन चाहिँ पोखराको सभागृह चोकमा एउटा महिलाको हत्या भएको छ र अमेरिकामा चाहिँ एउटा परिवारको हत्या भएको छ। मेन्टल हेल्थको इस्यु चाहिँ हामीले स्कुल लेभलदेखि नै बालबालिकाहरूलाई चाहिँ सिकाउनु पर्छ।
Thank you. We've been stressing that for the session. I saw. I'm sorry. We'll have to close this session very soon.
Okay,
I'm just so. No, please. I'm giving you.
Thank you very much,
lady. Right?
Thank you very much, ma'am.
Gentlemen have commented a lot. Let her have.
I'm Manisha. I'm a transgender woman. मेरो concern चाहिँ LGBTIQ related mental health issues हो जो चाहिँ यहाँ धेरै चर्चा भएन र mental health issues LGBTIQ मा general population भन्दा many times धेरै छ भन्ने कुरा यहाँहरु सबैलाई थाहा नै छ होला। हामीलाई चाहिँ यसको कारण चाहिँ के छ भन्दाखेरि हामीमा एउटा minority stress हुन्छ र very limited trained mental health professionalहरु हुन्छ जसले चाहिँ हाम्रो इश्युजहरु बुझ्नुहुन्छ हैन। हामी सर्भिस सिक गर्न जाँदाखेरि हामीलाई कहाँ रिफर गर्नुहुन्छ भने रिहेबिलिटेसन सेन्टरमा रिफर गरिदिनुहुन्छ मेन्टल हेल्थ प्रोफेसनलहरूले, ताकि ड्रग्स र अल्कोहलको रिहेबिलिट ताकि हाम्रो जेन्डर आइडेन्टिटीलाई करेक्ट गर्नको लागि र कन्भर्जन थेरापी हालमा हर्मोन रिप्लेसमेन्ट थेरापी दिएर हाम्रो जेन्डर आइडेन्टिटी करेक्ट गर्नको लागि त्यो इभिडेन्सहरू हामीसँग छ। त्यसको चर्चा पनि हुनुपर्छ हैन। मैले भन्न खोजेको जुन स्ट्र्याटेजीको हेल्थको स्ट्र्याटेजीहरू यहाँ देखाइयो 5 इयर्स स्ट्र्याटेजी, त्यो स्ट्र्याटेजीको क्यापेसिटी स्ट्रेन्थेनको पिलरलाई टेकेर मेन्टल हेल्थ प्रोफेसनल सँगसँगै इन्टायर हेल्थ केयर प्रोफेसनल्सहरूलाई चाहिँ यो ओरिएन्टेसन प्याकेज एलजिबिटिआइक्यूको इस्युजमा ट्रेनिङ मोडल चाहिँ त्यो चाहिँ हुनैपर्छ भनेर यो सेसनको रेकमेन्डेसन चाहिँ भोलिको डेक्लरेसनमा पनि जाओस् भन्ने चाहन्छु.
Thank you for raising a very pertinent question. Thank you for the interest in mental health. I see Dr. Suvedi is sitting here, Dr. Buddha Basnet is here. And what has been so heartening for me is the participation of young people. It is, you know, I think public health especially is in safe hands. I'm very impressed to see the energy in the room. Keep it up. Keep it burning. Thank you. It's a Gen Z era. Yes, indeed. Thank you. Okay, sorry. Alikiti यहाँ communication gap bhayech. There's token of love which has to be handed over. Dr. Maske, why don't you go and do the honors? Okay.
Thank you so much. Thank you very much to all the invited experts and presenters for the wonderful presentation. And I would like to express my sincere gratitude to both of our respected chairs. And your intensive experiences and guidance in the field of public health are truly inspiring and indeed a source of continuous motivation for the young leaders, researchers like us. Now it's time to honor the contribution of our presenters with token of love, and I would like to call the name of our presenters one by one. Also, I heard that Dr. Binita Dhungel has already left, so I would like to request Dr. Jivan Ghimire to kindly come on the stage and receive the token of love on her behalf. Next, I would like to call I would like to provide token of love. I would like to request our esteemed chairs, both of our chairs, to provide a token of love to our presenters. Next, I would like to call Dr. Sachin Ghimire. Dr. Sachin Ghimire. I think Dr. Pushparaj Paudel is not in this hall. Mr. Prakash Pasupati Mahat. Mr. Umesh Belwase. Dr. Jivan Ghimire. Ms. Rinasa Ghimire. Mr. Pushparaj Paudel. Mr. Gaurav Patrai. Ms. Babita Ghimire. Ms. Sabina Dangol. Oh. Miss Sabina Dangol. ड्यासमा गएर ग्रुप फोटो खिच्दाखेरि हुन्छ सर. Excuse me.